Good morning, all. Good morning, all. I hope my voice is audible. I, Miss Priyanka Khidekar. Can you hear me? I request all the participants to share the to reply. Can you hear me? Good morning, all. I, Miss Priyanka Khidekar, representative from Department of Nursing, MGM Medical College and Hospital, Kamothi, welcome you all in the webinar on patient safety and overview on patient safety goals. Theme: Speak up for patient safety. Nobody should get harmed in healthcare facility. I request everyone to please fill up the pretest. The link is already given in chat box. I am repeating. I request everyone to please fill up the pretest. Link is given in chat box. I am repeating. Link for pretest is given in chat box. Kindly fill up the pretest. Good morning, all. I am repeating. Please fill up the pretest. Link is given in chat box. If anybody is not able to open the link, kindly message.
Good morning, ma'am. Good morning, madam. Yeah, myself is Padmaja Dhawde. Good morning. I welcome you, ma'am, for this CNE session as an observer. Thank you, ma'am. As an organizer of this CNE. Thank you, ma'am. I hand over this to Ms. Priyanka Khedekar, who is hosting the CNE. Thank you, ma'am. 1 minute, madam. I will start my mic. नाही हेडफोन मध्ये मला आवाज येतोय तुम्हाला? आवाज येतोय तुम्हाला? हॅलो हॅलो मला काहीच नाही ऐकायला येत आहे. एक तरी ऐकायला यायला पाहिजे ना.
Good morning, all. I'm receiving comments that your people are not getting the link for pre-test. It's given in the chat box. Kindly find there. Still, if you are having any issues to join, kindly message in the chat box. Thank you. I hope everybody has filled up their field test. We will be starting the webinar soon. Again, good morning all. I, Ms. Priyanka Kerekar, representative from Department of Nursing, MGM Medical College and Hospital, welcome you all in the webinar on patient safety and overview on patient safety goals. Theme for the webinar is Speak Up for the Patient Safety. Nobody should get harmed in healthcare facility. Moving further, for the unfolding of the theme, I welcome Dr. R. Ponchitra Madam from MGM New Bombay College of Nursing, Kamothe. Ma'am currently working as professor and vice principal in MGM Indicon. Ma'am has pursued her PhD in nursing and currently pursuing FAI MER fellowship. Ma'am has over 18 publications, worked as editorial member in international journals. I welcome ma'am in the unfolding of the theme. I hand over this webinar to Dr. R. Ponchitra Madam. Thank you.
Thank you, Ms. Priyanka. Good morning to all the participants and the audience who have registered for this webinar. And it's my privilege to open the theme for this national webinar on patient safety goals. Patient safety is the cornerstone of high quality healthcare. Patient safety has been increasingly recognized as an issue of global importance. It's defined as the absence of preventable harm to a patient and reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. Patient safety goals are evidence-based standards to improve the safety and quality of care provided. These standards directly impact the way the registered nurse practice in the healthcare organization. The Hospital National Patient Safety Goals 2021, according to Joint Commission, is to identify the patient correctly, improve staff communication, use medicine safely, use alarms safely, prevent infection, identify patient safety risks, and prevent mistakes in surgery. The emphasis on patient safety goals will create great pressure on the system-wide processes for addressing the medical errors. The Institute of Medicine addresses safety as a system property. This rule requires that patients be safe from injury caused by the care system and that more attention be made to preventing and mitigating errors. Nurses are the largest group of healthcare providers offering direct patient care. They play a critical role in prevention of adverse events and optimization of health services, productivity, and patient outcomes. Nursing has been clearly concerned with defining and measuring and improving the quality. The most critical contribution of nursing to patient safety in any setting is the ability to coordinate and integrate the multiple aspects of quality within the care directly provided by nursing and across the care delivered by others in the setting. Nurses are vital for patient safety and hence focus on education of patient safety has become the focus recently. In line with this message, the theme of today's webinar is patient safety and overview. Here we have sessions on introduction to international patient safety goals, correct identification of patient and effective communication. This followed by safety of high alert medications. The third session is on surgical safety and the fourth one is on prevention of fall risk assessment and the final session will be on prevention of healthcare associated infections. So this topic is the need of the hour and I hope since all the corporate hospitals and every hospital is going for accreditation and there are various quality indicators which are based on these patient safety indicators, I think it's very important to educate all the nurses as well as the students who are studying also right from their student period also to be concerned with the patient safety goals. Thank you, Priyanka. Over to Priyanka to proceed with the sessions.
Thank you so much, ma'am. Moving further, I take this opportunity to welcome all the participants present for this webinar. Moving further, I am welcoming Mrs. Pradnya S. Kadam, Principal, Navanirman College of Nursing, Sangameshwar, Ratnagiri, as Maharashtra Nursing Council observer with us. Madam has completed her GNM from MGM Parel in 1997, followed by BSc from KLE Belagavi in 2007, MSc in Community Health Nursing from Krishna Nursing Institute, Karad in 2013. Madam is currently pursuing PhD Nursing from JJTU University, Rajasthan. Madam has experience over 25 years in clinical and education field of nursing and act as an inspector, examiner in staff approval committee in MUHS, Nashik. Madam has published many articles in journals. I welcome you, ma'am, for this webinar.
Thank you, ma'am.
Moving further, we have an eminent personality among us to start with this webinar. That is Dr. Colonel Philomena Isaac, madam. Madam has completed her DGO in 1984 and Master in Surgery OBGY in 1993. Madam has served Indian Army for 35 years, actively participate as medical officer during Kargil War, worked in MGM Medical College and Hospital, Aurangabad from 2006 to 2019 as medical superintendent and quality head. Currently working in MGM Medical College and Hospital, Kamothi, Navi Mumbai as Chief of Quality and Medical Administrator since February 2019. Madam acted as key person in achieving NABH accreditation both in Aurangabad and MGM Kamothi. Madam, I welcome you for this webinar. Over to Dr. Philomena Isaac.
Good morning, everyone. I'm Dr. Colonel Philomena Isaac. I'm here with MGM Hospital, and thank you, Priyanka, for the introduction. Today, I will be talking about giving you an introduction to staff and patient safety, and also an introduction to the International Patient Safety Goals. The importance of safety, patient safety cannot be overstressed. Every day you hear in the newspapers, on the news, on the television about something or the others, patient harm which took place due to any reason. Just like we hear about safety at your home, safety in your kitchen, safety while you're traveling, there is something which is called safety in healthcare services. Now, we know that in hospitals, we are all responsible for the patient's safety. And the most responsible people are the nursing staff who are along with the patient 24 hours a day. Around the clock, they are with them. I once heard Abdul Kalam say, the nurses are like angels going around the corridors of the hospital, taking care of the patient, giving them confidence, giving them a sense of well-being, giving them a sense of being safe in the hospital. There is someone who's here with me round the clock, just like Florence Nightingale, with her lamp, walking down the corridors of the hospital. She was the one who first brought safety, the importance of safety for all the nursing staff during the Crimean War. She's the one who taught them about the basic cleanliness, washing hands, the basic disinfection protocols as a safety measure to prevent infections in these wounded soldiers. So every organization needs to have a safety policy. Your policy should be the health, safety, and welfare of all the patients and the healthcare workers, because we are equally to remain safe. If you have a healthy healthcare worker, you have a healthy, safe patient. We need to be safe, and safety involves all together. Everyone who comes to the hospital, working on your visitors also, everyone needs to be safe. So it is defined as a protection against unnecessary harm resulting from healthcare service efforts or lack of efforts. Now, both ways we see that we do routine work in the hospital, taking care of the patient, starting from their admission up to their discharges, their interventions, all the protocols that we follow in the hospital. We put in a lot of efforts to take care of them, doctors, nurses. But a lack of efforts is also there, which is one of the reasons for harm. Now, WHO has realized it, NABH has understood it. We know that the NABH, we see the logo of NABH, it says patient safety and quality. That means safety comes first. And it has been realized that safety has become such an important issue. There are so many deaths daily, so many patients dying due to harm while under treatment in healthcare services. And World Health Organization, they declared a World Patient Safety Day on 17th September 2019. This is to promote an awareness and have a involvement of everyone, an action plan for preventing any kind of harm to the patients. And these are other initiatives which were there earlier. You have heard about them earlier. Clean care, that is prevention of infection, basic universal precautions, safe surgery, safe lives. You have seen the surgical safety checklist, which we all follow everywhere in the world. This is all the initiatives from WHO. Medication safety and patients for patient safety is something which they have introduced so that the involvement of patients in the patient safety program is also important, because unless they are aware of it, it will be difficult for us to take care of them. Their involvement of it is equally important for the safety program. Now, what is patient safety? Unsafe care is one of the 10 leading causes of death and disability in the world. So you can see the importance. It's even more than any accidents you hear all around the world. We hear of accidents, trains and airways of traveling and other diseases. But you see, 1 in 10 of the leading causes is due to may cause death or disability. But whatever injuries or harm that patients encounter while they are under healthcare treatment, almost about 30% of them may have death also, apart from the disabilities and other injuries that they sustain while they are under treatment. So the importance of this has been understood all over. That's why NABH gives more importance to safety rather than quality. Earlier, there used to be a chapter called CQI, Continuous Quality Improvement. Now it has been changed to PSQ, that is patient safety and quality. So more important is given to the implementation of these safety protocols rather than the documentation. Now you see that the important thing here, the amount of deaths that take place, 2.6 million deaths take place annually everywhere. Every day there are thousands of people who are getting harmed. But the important thing to note is that 80% of this harm is preventable. So we can prevent it. Now, why does harm happen to a patient? Harm takes place due to human error. Now, while we are giving medical treatment to patients, we are definitely not intentionally harming them. Whatever harm happens to them is due to partly due to omission, errors, some amount of negligence, which maybe require some amount of counseling, but most of it also is due to poor communication and lack of experience. So if we don't train our healthcare workers properly, it's quite likely that they may miss out on the protocols, miss out on checklists, and lead to harm of the patients. That's the reason why it happens. And definitely one should not think that I've done a big crime if it happens. We all do mistakes. There's nobody who is absolutely 100% correct. So if at all harm does take place, it is definitely not punishable. And this is something you must realize, that if something goes wrong, the thing to do is to correct it, to improve it, to prevent it happening again. And most of it is also communication gap. If there is a good communication, a good teamwork among all healthcare workers, this kind of harm would definitely come down to the minimum. Now, one has to understand what are the various safety aspects. We can broadly classify them into fire and non-fire problems that we can encounter in the healthcare services. Just like in any other services, whether you're traveling or you're in a mall or you're at home, everywhere there is some amount of risk and danger, and safety always should be kept first in mind because we need to be safe. So there can be dangers due to any of these things. Fire, non-fire, like an electrical spark leading to a fire, an electrical problem leading to electrocution or electric shock. Burns, hazardous materials are so much in the hospital. We are exposed to infectious waste, blood, and needle stick injuries. There are chemicals, there are medical gases in the hospital. There are various types of lab chemicals, disinfectants. All these are hazardous. Hazardous not only to the healthcare workers, it is also hazardous to the patients. So everywhere patient safety and staff safety comes together. Occupational hazards affect mostly the healthcare workers, in which you have physical hazards, biological hazards, workplace violence, which we are seeing almost daily somewhere or the other. Healthcare workers are exposed to these kind of safety risks, and indirectly it affects the patients, because when you have a safe healthcare worker, you have a safe patient. In diagnostic services also there is a safety issues, and that's why you have safety programs for the lab, laboratory, and radiation safety. So there is a chapter called Patient Safety and Quality in which the patient safety program has been described, has been elaborated upon, and everyone needs to read about safety. Read, every hospital will have standard operating procedures. There is a safety committee in every hospital to understand these safety issues, study them, do facility rounds, take an active risk assessment, and see what are the hazards, what are the dangers, stop it before it happens. So that is the importance of a safety program, that you prevent anything adverse happening. Adverse events will take place. You have to report it. But you cover these kind of incidents and prevent it happening again. That is the importance of a safety program, and that is the importance of a safety committee, which has various committee members, and all kinds of events should be analyzed and these round reports. So the safety committee has this importance because there is a safety officer who looks after the safety of the whole organization. Okay, starting from security to staff safety to patient safety to safety in your facilities. Okay, clinic, the structures that you have in your buildings. Okay, anything can happen. Your electrical safety. The safety committee, that's why the safety committee has safety officers. Even the clinical safety is there. There's a clinical safety officer. And they all have this responsibility to analyze, to inspect safety devices, study all the incidents and see that it doesn't happen. So what is important for us is reporting this, having this culture of safety. In PSQ 6, it talks about culture of safety. Now, this is a culture which has to be inculcated by all organizations, whatever it be. And we in healthcare organizations have an importance of having this kind of a safety culture in which you need to have this culture of reporting incidents. Now, you know that there are various types of incidents, adverse events and sentinel events, near misses and no harm events, adverse drug events, and so many others. Reporting them is something which we need to encourage. When you encourage it, it becomes a culture of safety, so that everyone knows that I have to report. Even I almost dropped something or almost gave a wrong medicine, I need to report it. If they don't report it, they say, oh, why should others know that I almost made a mistake or I did make a mistake? I need to hide it. So that's not a culture of safety. A culture of safety is bringing it out. You will be appreciated for bringing out some kind of constraint rather than a mistake or a wrong thing that you have done. It is not that. It is just something that would have happened, and we can take precautions next time that it doesn't happen. But if you just hide it, it's going to happen again because you have not informed about the incident and asked the safety committee to take measures to prevent it. So it's important that we have this kind of a safety culture, and this safety culture can come by validated surveys. At least if you do a survey once in a year, you can find out what is the attitude of your staff, the attitude of all categories of staff. It's not only the nursing staff who is responsible for the safety. It is doctors, the nurses, the technical, non-technical, the class 3, class 4. Everybody is involved in patient care, and everybody needs to inculcate this culture of safety. And it is the responsibility of the organization to provide adequate resources and funds for their safety. That is why we go in for the NABH accreditation, so that we make sure that all these protocols are in place and your patients and you are safe. So, and with this comes the performance improvement targets, particularly those related to safety, and everywhere you set a target. So incidents will take place, adverse events will take place, but you set a target to reduce that. And that is your target for improvement. And quality comes from safety. So yes, we have to have the involvement of everyone there as a team. So providing a safe environment is the responsibility of the organization. And everywhere we need to have the patient safety devices. You know that, you are aware of it, each and every. And definitely the nursing staff who are with the patients more throughout the day are more aware of these safety devices, which if there is a shortcoming anywhere, or you see there are not enough of the grab bars in the toilets, or there is a slippery tiles somewhere, or there is an open cables, electrical fittings are loose, Loose wires are there, open wires. Yeah, you need to be conscious enough to say, oh yes, this is a safety risk. I need to take action. You see a patient being transported without a safety belt. Yeah, it is our responsibility to say, yes, please do something about it. We don't want that patient to fall down. So we have that kind of culture and we inspect all these safety devices. It's also important now, it is the involvement of everyone, including the facility management people, those who manage the biomedical equipments, those who manage the buildings, the plumbing, the electrical fittings, the medical gases, everything has a safety issue in it and they all need to be aware of it. And everybody else needs to be aware of it to report whenever they see something going wrong. So the hazardous material, spillage management, everything is taught as a routine and we need to follow it. The importance is also to put up adequate signposting. Now, when you see signpostings, you know exactly how to save yourself and save your patients, save their visitors, everyone, when you know what action is to be taken when there is a fire. So the patient safety relates to fire and non-fire emergencies, and the escape routes are very important when they are clearly laid out for everyone to see. In all hospitals, you have this because you need to know and patients need to know, because patients are also to be involved in the safety plan and safety program. Non-fire emergencies is something which the safety committee needs to know about. You have to know that everywhere we are at some kind of a risk nowadays due to, say, terrorist attack, earthquakes you hear of, building collapses you hear of, natural calamities take place, and man-made calamities, whatever it be, we be aware of it, be ready to face it and take correct action. Housekeeping itself also has got its safety issues, like not preventing smoking in the area. It's a fire hazard. Keeping corridors and exit doors free of obstructions, where we find garbage and all, littering up and clustering up the exit routes. You find pests in the hospital. Housekeeping has got its own importance. So decontamination and disinfection protocols, all part of this is also related to patient safety. Occupational hazards, we will not go into the details because this is more related to the staff and healthcare workers, where physical hazards, biological hazards, and all psychosocial hazards are affecting our healthcare workers, but they indirectly affect the patients as well. Therefore, we need to take care of all kinds of hazards. Biological hazards is something which is relevant for healthcare workers as well as the patients as well. So we want to prevent any hospital-acquired infections. We need to know about hospital-acquired infections. We need to be ready with all the preventive aspects for each and every hospital-acquired infections, prevented, proper biomedical waste disposal, preventing injuries due to waste disposal. Hazardous material is something I already talked about, can cause a lot of injuries and can affect healthcare workers as well as patients, particularly those who are going in for radiation. So radiation hazards, one needs to know about, take care. So what are the various hazardous materials? Would be body, blood and body fluids, medical gases, and lab chemicals. That's why you have a material safety data sheets for lab chemicals, because exposure to it can affect healthcare workers. Radioactive materials and nuclear isotopes, chemotherapeutic drugs, pesticides, inflammable material, which is there in the hospital and in the surrounding campus. So we need to put up a whole lot of precautionary signposting so people know where there is a radiation hazard. Laser, we know, is in physiotherapy, and we tell people be careful because that also can adversely affect healthcare workers as well as patients. Radiation, slippery wet tiles, everywhere you put up signposts so you prevent any kind of injury. These are various signs posting which are required for the healthcare workers, because even your construction worker is very precious. Your housekeeping staff is precious. Everyone is precious. They need to be safe. So warn everyone of the danger. We know that even high noise level can affect our healthcare workers. People who are working in the DG set or the chiller plants where a lot of noise is generated can have sensory neural deafness after a period of time. We need to protect them everywhere, protect them with signposting, giving them devices to protect themselves. Now, about adverse events, sentinel events. Now, these are patients and healthcare workers. Anyone who within the facility of your healthcare services can have any kind of adverse events, and even near misses, adverse events, and sentinel events. Sentinel events is the other extreme of an adverse event, where a death or a long-lasting disability takes place. Sometimes you have a patient who has come for a cataract operation. He's perfectly fine. And he's walking down your corridor, your staircase, and it's slippery there, and he don't have a proper railing or a proper ramp, and he just slips and falls and fractures his leg. So he lands up with a fracture femur. He's come for a cataract operation. A fracture which is a disability, which is a long-term disability, which is going to keep him in hospital for more than 15 days. So that would be a sentinel event, and that can be due to surgical events, a wrong surgery, wrong patient, a wrong part operated, retained instruments, and surgical deaths, anesthetic deaths. These are all surgical events, sentinel events. Device and product related also contaminated drug devices, breakdown of equipments, air embolism. These are all due to devices that we get. Sometimes you hear of extubations and problems with the intubations. So wherever the products, the devices are there, we need to be careful, see that they don't land up with a sentinel event. Others, we hear of Code Pink, where a child may be kidnapped, abducted. Then sometimes a child is discharged to given to a wrong parents. And anywhere where there can be patients who have a self-harm, leading to a disability. Sometimes you hear of burns in the hospital due to a defaulting devices. And wherever patient have to be protected, wherever there has not been a careful monitoring of the patient or taking care of them at all times, they need close observation. Where there is a little lapse or little negligence, you can land up with a sentinel event. Environmental events, even use of restraints can lead to a really severe neurovascular deficit when they are not monitored properly. So everywhere, healthcare workers become very, very important and responsible to prevent all this. It can be due to mismatched blood transfusion, maternal deaths in high risk, medication errors is a very common thing. It's a very, very common thing. So we need to concentrate more on these kind of incidents in the care management. During your care, you're giving a blood transfusion, you're giving medication, you're taking up patient for surgery. Everywhere there can be errors and the patient put at risk. Criminal events, of course, happens all over the world. Impersonation, abduction, assaults, sexual assaults, deaths can take place, suicides can take place. So we need to safeguard against all these kinds. Now, everybody knows about these emergency codes, and I don't have to bring it out here, but a system of knowing about it and acting on such incidents which take place immediately, within seconds, alerting people can save lives. And these kind of drills need to be conducted regularly so that we are aware of it, take action. When a real incident takes place, we are ready for it, and everything is done in a good, systematic, planned way. So there is least amount of damage done when you are well organized. Now, we know the quality key indicators, which used to be about 72 in the 4th edition of NABH. Now we have 32 indicators which are mandatory key performance indicators, and we need to monitor them regularly. On a day-to-day basis, it is done by your quality department and your quality cell. And there are, out of these 32, there are most of them, a number of them, which are related to safety issues. And we should be aware of these key performance indicators like adherence to safety precautions in diagnostics. Now, in diagnostic services, I've already spoken about it, like there are chemicals, there are biohazardous material, there culture material there. So they are at a greater risk. How well they adhere to precautions like wearing gloves and masks and PPEs, and being aware of material safety and the actions to be taken in case of any exposure to any acidic kind of lab chemicals is a very important thing which needs to be monitored. Medication errors is something you all know, everybody knows, it happens and it should not happen. How do we reduce it? So if it does happen, you need to report it as a key performance indicator, investigate it and prevent it. Error-prone abbreviations is something which doctors are doing all the time, in spite of telling them that it can cause a big problem because you're using an abbreviation. It can be misunderstood for another drug. You're using an abbreviation which can be deciphered in a different way and you give a wrong medication. So error-prone abbreviations are not to be used anywhere, particularly in writing prescriptions. Adherence to procedures to prevent, this is a surgical safety which has to be done meticulously in the operation theater for patients and also for interventions, any kind of interventions and major surgeries, minor surgeries, even like doing say pleural tapping. It can be a wrong side or a wrong patient or whatever. Everywhere you need to adhere to the protocols, IPSG, to prevent such things happening. Pressure ulcers is also a patient safety issue because wherever there is a little bit of negligence in taking care of these bedridden patients who are non-ambulatory, they are going to land up with pressure ulcers. So here the importance of the nursing service cannot be overstressed. You can prevent it because pressure ulcers can start within 24 hours of a patient just lying on his back. Hospital-acquired infections, you have your hospital infection control team, and it is their responsibility to prevent it. And if it happens, they are to be monitored as key performance indicators. There are 4 hospital-acquired infections which we are all aware of, like surgical site infection, COTI, catheter-associated urinary catheter, and central line-associated infections, and ventilator-associated infections, VAP. So these are all hospital-acquired infections, and we need to safeguard ourselves and prevent it as much as possible. Hand hygiene compliance is something which is monitored by the observers. And this is also reported as a key performance indicators, because when you don't monitor it, it's going to slip off and people are not going to comply with it. So we need to keep on stressing the importance of it, those various moments of hand hygiene. Mock drills is something we need to do, as I told you, on a routine basis, at least once in 6 months. You do all this code pink, code blue, code red, and mock drills for mass casualties, all these kind of emergencies. We need to prepare ourselves. Therefore, it's also a key performance indicator to monitor how well they follow a protocol. And the more you do it, the better you get, and you get perfect in it. And then any kind of an emergency, you're ready for it. Patient fall is something which happens many a times. And everywhere where we as healthcare workers forget to take care of these kind of incidents, making sure that the patient has a railing on the bed, particularly vulnerable patients, slippery tiles, no grab bars or side railings. These kind of things we need to see, which can help to prevent patient fall. And if it takes place, we need to investigate it, do a root cause analysis, find out why it happened, and see that it doesn't happen again. Near misses is something which people don't like to report. They say it's not important that I almost gave a wrong drug, but why did it happen? And prevent it happening again is very, very important. Needle stick injuries happen all the time, particularly with young student nurses who start working in the hospital. They are not aware of the protocols. They have not been taught. So we are to blame when we don't teach them before we put them into patient care areas, when they are trying to recap a syringe needle and they prick themselves. So this happens quite often. You will see, and then you need to do all those tests. So prevent it. We want no harm for our healthcare workers and the patients. Now we come to the Joint Commission of International Patient Safety Goals. In these, I'll give you an introduction to it, and I will talk about the first two of them. The others will be covered by the other speakers today. Identify patients correctly is the first goal. Communication, effective communication is the second goal. Improve the safety of high alert medication, that is safe medications, is the third goal. Right site, right patient, right procedure, that is safe surgery, is the fourth goal. The fifth one is reduce the risk of healthcare associated infections. And the sixth one is reduce the risk of patient harm from falls. I talked about falls also a bit. So there are additional national safety patient goals of 2016, which are also important apart from the 6 which are international patient safety goals. That is prevent healthcare associated pressure ulcers. I talked about pressure sores, pressure ulcers. You have various grades of them. Wherever there is a little bit of neglect or negligence in taking care of non-ambulatory patients, you need to prevent it. Identify patients at risk for suicide. This is something you hear quite often. There are so many people who come to hospital and under a lot of psychological pressures and risks. You may think they are okay, they may be in depression, but there is a big risk. If you don't monitor them or closely observe them, they would be vulnerable. So one needs to identify these people who are at a risk for suicide. Implement safe transfusion practices is another thing that also is included in the national safety goals. The objective of the IPSG is to promote improvements in patient care and safety. You highlight the problematic areas by these patient safety goals. You understand where are the shortcomings, improve on it. So you describe the evidence and expert-based consensus solutions to these problems. So that is the objective. The objective is to find solutions and prevent it. Okay, this is a repeat of the same thing. The pictures, you should remember these 6 goals. It's important for all healthcare workers to know it, display it, so that people remember it. Now I come to the first goal, that is identify patient correctly by 2 identifiers minimum. You can use more. 2 is the minimum. That is name. And what we do in our hospital is the patient's number, IPD number, or the unique identification number. And that is because in our country, our names are so common. Even our surnames are so common that so many people have the same surname. So many people have the same name. So you need a second backup, particularly when you're dealing with a patient who is sedated. It doesn't talk properly, he's unconscious, and you have to identify him to send him for a protocol or a procedure. Or you're taking his blood for a sample. Okay. You're providing certain treatment protocols, undertaking or giving him certain medications. So before that, you need to identify it. Now, many a times we say, we know the patient, it's on that so-and-so bed and I have given it earlier. But it can be quite possible that the bed is shifted. So you never use a bed number as a identifier. You don't use a telephone number. Okay? You don't use a sticker on the patient's clothes as an identifier. Okay, but you need at least perfect identifiers, like what you can use is date of birth, okay, and some other address proof and things like that. Those are more identifiers than a bed number or a room number or a sticker somewhere. You don't use that. You use a band, identity band, which is on the patient's wrist. Okay, it has a digital kind of an identifier, a barcode or whatever, and you correctly identify the patient, particularly before treatment and procedures, before you're giving a drug, or before you're starting a transfusion, before you're taking samples and protocols or procedures. So it's very important that this becomes a habit for you. You do a double check. Is it the correct patient? Is it the correct procedure? Is it the correct site? Everything. You identify the patient correctly by a minimum 2 identifiers. And the best in is the unique patient's identification number. So that is unique for every patient. Follow that. So these are the accepted identifiers, the name, the address, and name is something which people in Arab countries, they say you use 3 names rather than 2 names. Use the full name with the address, photo IDs, date of birth, don't use the other things. Now, the second IPSG goal is improve effective communication. Now, when we are children, we play some games, we whisper to one another something in their ears, and then it is communicated to a next one and a next one and a next one in a big chain. And when it comes back to the original person, it is totally distorted. It is lost its meaning because you've said some difficult words and difficult treatments and difficult protocols. You talked about the patient's history. You've talked about his surgical procedure. And by the time it has gone around and communicated, you have talked about a patient's critical report. By the time it has gone that side and then communicated to the 3rd person and 4th person, it can be distorted and it can lead to a safety risk. So improve effective communication. In the NABH standards, there is one PRE, Patients' Rights and Education, PRE 8, which talks about effective enhanced communication. And it's very important for all of us to know what is effective enhanced communication. So verbal and telephonic orders, when you give, there can be mistakes. And it's very important that we give it clearly, concisely, concretely, and it is effective when you have a read back system. So what do you do for effective communication? The whole test, whenever you take a verbal kind of order, you listen to it on the telephone. Somebody has given a verbal order to you, your consultant or whatever. You are writing it down. After writing it down, you have to read it back in the same order correctly. And then it has to be reconfirmed by the person who gave the order. Then alone you know that there is no mistake in it. Okay? So the 7 C's of communication, it's clear, it's correct, it's complete, it's concrete, concise. You don't make a big long story of it so that it's concise and clear. It's considerate and courteous. These last 2 are more for enhanced communication. The other 5 are meant for, when you're talking about patients to one another. So where do you communicate? You communicate between nurses to nurses, nurses to doctors, doctors to doctors, doctors to patients, nurses to patients. Okay, everywhere, wherever you are communicating, you follow these C's of communication. And there has to be a teamwork when you communicate, so that you communicate in a courteous, considerate, proper way, and things are followed in a proper way. Now, this is something which is very important in all situations. It started in the US Army and the Navy, where they used to, they formed this kind of a toolkit to understand clear communication, because you cannot make mistakes when you're in a war situation, when you're identifying a patient, also in a healthcare situation. Here, it's very important for nurses and doctors to give a very, very clear communication. And if you have a toolkit which tells you what are the things you need to do when you're going to communicate some important information, particularly a critical result of a patient, which needs immediate action, or a critical condition of a patient, which needs immediate action, emergency surgery and things like that. So you need to clearly communicate. Firstly, you identify yourself, your location, your position, and the patient's name. Identify the patient and tell correctly. Situation, why are you calling? What is the whole situation? What is the patient's condition, his temperature, his pulse? You're telling what exactly has happened. The patient has become dyspneic, or the patient has got seizures, or the patient is having acute pain. Whatever the situation you are telling, that is the situation. You're describing it. And then the background is the background of the story. When you start it, you don't say this patient is having dyspnea. You say, okay, he's a case of COPD and he's suddenly become very, very dyspneic. Okay. Or a patient is on an IV line and he has suddenly developed fasciitis, or deep vein thrombosis has been developed. Whatever you're telling, the background of the story starts with the patient's history, a little bit of it. You don't have to tell a very elaborate long, others the whole thing is gone. A short background of what is happening. An assessment, what your assessment you have to tell. That what you think is going on, what is happening to the patient, you have to give your assessment, because you are conveying it to somebody who is not around, particularly these kind of things in late night when there is nobody around and you are fully in charge of the situation and something adverse has happened. You need to assess your assessment, tell them, and then you give your recommendations. R is for your request or your recommendations, what you recommend and what you want from them. So this is the ISBAR tool, and you can have a practice sheet in which you can do. I is there not will put there, because you know you've got to identify yourself and the patient and where you are. Then you have a kind of a column in which you write down these things. You jot it down quickly, and then it becomes easy for you to use it as a toolkit to tell somebody the importance, so you don't miss out on anything that you are communicating. Use this ISBAR tool, but don't waste time on it. People say, oh, it takes a long time to do all this. And, but when you do it as a routine, it becomes a very quick thing. You can do it within a minute. So documenting it and then doing it, because you don't miss out on anything, and the whole communication is very concrete and clear and correct. There's no mistakes here. Another important thing for us to understand is the verbal orders. Verbal orders is something which you are receiving in communication from somebody. A doctor, a consultant is giving a particular verbal orders about drugs or certain preparations to be done for a protocol or procedure. In a code blue situation, you're taking a verbal orders. Then when the patient is in a very serious condition, or when insulin is to be given, or the patient is on a inotropic drug and a continuous infusion is going on, and you need to titrate it against the BP, like a medication for his hypertensive condition and insulin. So you cannot wait there, and you got to take the verbal orders. There is a list of verbal orders, drugs also, medications, which you need to display, and you need to train all the nurses. You need to know about it. What are those kind of verbal instructions? Because certain other important drugs like narcotics and chemotherapeutic drugs and reserve and restricted antibiotics, high generation. You don't normally say, okay, I heard it and I'm giving it. You have to write it down, get it authenticated, signed, and then do it. But when there is no time, you take a verbal order, you double check it, and then you correctly do it after having double checked it. That is the read back procedure, which I have already told you. So only after you confirm it that it is the correctly done, correctly heard, correctly documented, rechecked, reconfirming, then alone you carry out the treatment so that there is no scope for error. So I have told you about the first two international patient safety goals. Seek safety, aim safety, follow safety, ensure safety, teach safety, and yield to safety. So this is very important, particularly for the nursing staff, where you are the pillars of the healthcare services. You are the most important. You are the guardian angels of all the patients, and the patients, get them involved into this safety process. Get yourself involved. Get everyone involved. That is the teamwork that you should have. Your patient also becomes part of your team in this safety journey where you identify, and it starts with you. You start this journey. Thank you.
Thank you, madam. Thank you, madam, for your detailed speech. This gave us insight to identify the patients correctly for safety precautions and how to follow it in practical environment. Moving further, I welcome Mrs. Padmaja Dhavre, Madam, Nursing Superintendent, MGM Hospital, Kamote, to share her views on safety of high alert medications. Madam has completed her GNM in 1993, her PBBSc in 2001, and MSc in 2009. Madam has over 27 years of experience in nursing education, clinical and administrative field. I welcome Madam to continue the further sessions. To all participants, before that, to all participants, if you have any issues with the audio, kindly share your views in the chat section. Thank you so much. Handing over to Mrs. Padmaja Dhavre, Madam.
Good morning to dear all participants. As Dr. Isaac ma'am has briefly told about all the safety measures related to the patient, those who are admitted in the hospital. So we need to think over the safety. And similarly, as she has mentioned that even medication is also an issue of a safety. First of all, I would like to tell you all that when the patient is admitted in the hospital, the patient gets admitted for the purpose of treatment. None of the person would like to come to the hospital just to enjoy. So when the patient is coming to the hospital, it is our prime responsibility of all healthcare workers that they should take care of the patient. The patient should be going home safely rather than developing any injury or getting any harm from the hospital acquired things. Like as she mentioned that the safety issues, it may be related to the construction, it may be related to the bathroom, it may be related to the tiles, it may be related to anything. But the majority of the hospital acquired is the infection as well as the medication, which is very high. So let us start with our topic today, that is safety of high alert medication and its management. I would like to tell you that medical errors are the third leading cause of death after the heart disease and cancer. A recent Johns Hopkins study claimed that 250,000 people in US die every year from the medical error. This data is of 2018. Whereas we don't get the proper data because majority of the time the death occurring due to the medical error is hidden, it is not being brought up. So approximately whichever it is being known, these are the rough figures. So more than 138 million patients are harmed every year by the doctor's error. We cannot say only the doctor's error, but it includes everything, that is surgical safety, and it relates to the all healthcare workers. As in errors in diagnosis, errors in medication prescription and treatment, and the inappropriate use of drug are the three main reasons why so many patients get harmed. According to the Geneva-based organization, only errors related to erroneous medicine prescriptions cost healthcare system around the world some around $42 billion, that comes around 37 billion euros. Now, when we talk about the medications, whether it is high alert, whether it is LASA, whether it is a simple oral medication, any type of drug which needs to be administered to the patient for the purpose of diagnosis, for the purpose of treatment, or for the purpose of prevention. So it is a prime responsibility here of a nurse who is administering the medication to the patient, that she ensures and she should be knowledgeable enough to know the effect of that medication, whether it is a side effect or whether it is a beneficial effect of the medicine on the patient. So let us see that what are these high-risk medications is. The high-risk medications are the medications that are most likely to cause a significant harm to the patient even when used as intended. For example, if we use a xylocaine for the purpose of treatment, though the xylocaine is used with the intent, but still it may have a side effect. And if it is unrecognized or if it is not taken care before, it can lead to harm. Although any medications used improperly can cause harm, high alert medications cause harm more commonly, and the harm they produce is likely to be more serious and leads to the patient suffering, and additional cost associated with care of this patient is needed. So, what is known is that usually the high alert medications, it occur medications error occur due to unrecognized things, like maybe it may be the daily habit of taking the medication from a particular brand. This may be a pharmacist problem that we may take, or we may dispense the medication by just lifting any by looking at the color. Or it may be a nurse habit that yes, the patient ने medicine लाया है, okay, this is of that color because she is used to giving that particular antibiotic and or any other medicine which she blindly gives without checking it. Another error it can happen, like because during the emergency, like code blue activation, because of the oral verbal orders, medications are loaded in hurry because at that time you just have to pay attention to the patient, that the patient should be revived of the situation. So while carrying out the verbal orders, we are in hurry and there are chances that these high alert medications are not being taken care to identify properly and then can then administer. Now, this high alert medication are those medications that bear a heightened risk of causing significant patient harm when they are used in error. It is mentioned here that significant patient harm. Significant is of very, very important that there is a harm that where the patient is either going to become a disabled or patient may be losing his life. So, Medicine, Pharmacy and Therapeutic Committee identifies medication that requires a safeguard at any step of the medication management process based on the review of internal and external medication error and or the sentinel event data. Now, you may come across with this medication error, sentinel event, adverse drug reaction. These are these certain words which we come across in our daily routine, where sentinel event is a result of the adverse drug reaction when medications are being administered, and it is a result of the medication error. It is ensured that the high alert medications are procured, stored, ordered, prepared, dispensed, and administered safely. So, when we talk about medication, it is not only the nurse who is coming into a picture that she is administering the medication, and hence it is her responsibility that she has done the mistake. This mistake can occur at all 5 levels, where from where the medication prescription it starts. So prescription, transcription, dispensing, and then the administration and overall observation of the patient post administration of the medication. It is very important. So error can occur at any stage of the medication. These are the list of the high alert medications. So you may know that there are various medications which are given in the emergency situations, and this require very depth knowledge about the medications. Whether you are loading the medication, there are a confusion, or there are certain words like sound alike word or look alike word, or medications like epinephrine, norepinephrine, dobutamine, digoxin. These are the important drugs which have the effect. It is usually used for the treatment or for the purpose of the diagnosis. Now, there are these medication errors when we talk about. These medication errors are the outcome of common risk factors. What are those common risk factors? These are the poor written medication orders, incorrect dilution procedure, confusion between IM, IV, intrathecal, epidural preparations. There is a confusion between the strength of the same medication. There may be an ambiguous labeling on concentration and total volume of the medication, wrong infusion site, look-alike and sound-alike product, and similar packaging. Strategies and standards which help for limiting, which is required for the implementation of the high alert medication is, first of all, the high alert medications, where everyone should know. It should be known to the pharmacist, it should be known to the doctors, it should be known to the nurses. So all these people, those who are coming as a team member in administration of the medication, right from the issue of the drug to the administration of the medication to the patient, these people should be well aware of the action and reaction of the drug. So the storage of the high alert medication in pharmacy, it should be done in a proper place. Whether it is being stored in the pharmacy, whether it is required to be stored in the ward, ICU, or if at any patient who is being advised to continue the drug at home. So even the patient education is also required. So let us see about the storage strategies, what should be done for high alert medication. All high alert medication containers, products, packaged and loose vials or ampoules stored must be labeled as high alert medication. All personnel should read the high alert medication labels carefully before storing to ensure medications are kept at the correct place. With your left or right hand, you may keep the medication based on the packaging or the color code which it is coming. All high alert medication should be kept in the individual labeled container. Wherever possible, avoid sound alike and look alike drug or different strength of same drugs being stored side by side. I can give you one example over here. Look alike, sound alike drugs are dopamine and dobutamine. Whereas even the Metrogyl IV fluid, Metrogyl injection, which comes in a small plastic container, 25% dextrose, mannitol, these are even ciprofloxacin. These are the medications which come in a small plastic container, and it is been stored together. Then there are chances of medication error that by mistake you lift up any of the medication and without checking you may administer to the patient. So it is better to keep this medication separately in a separate container with a proper label. Another thing is that when you are using the high alert medications, you need to use labels which will mention high alert. These are called as high alert stickers in applicable storage areas. So you can see in a picture that whichever it is high alert, these are being labeled as the high alert double check medicine labels, and it should be labeled with a red color so that it can be identified quickly. So use of red bins is applicable for the storage area. Labeling of applicable medications with a high alert sticker when not already labeled as such by the manufacturer. Manufacturer will never label the medication as high alert. It is our responsibility in the healthcare setting that when we are dispensing or when we are transcribing the medication, it should be checked and it should be stored with the proper labeling so that it is an alert which is created to identify the medication once you see the red label over it. Another strategy says that high alert medications not stored in a locked lidded pocket must be scanned when removed from the automatic dispensing cabinet. Now in India, these automatic dispensing cabinets are not being used much as we come across because majority of the public and government sector they don't have this facility. But soon it is available even in the private, some of the private hospitals or organizations. Wherever it is available, it is well and good, but where it is not available, there the medication error occurs very frequently and in high number. Whenever possible, ordering is restricted to order set. Now, these high alert medications, if at all it is required, it has to be ordered in a proper way that it should not be loosely dispensed by the pharmacy so that the medication errors can be prevented. For example, any person who is a layperson who is just going and telling the pharmacy medical store that XYZ has to be given to them, it should not be given. So restrictions of the order setting. Similarly, in the hospital setting, we consider it as the fentanyl injection or morphine injection or morphine injection is considered to be a part of a high risk medication. So when these medications has to be ordered, it requires a restricted order set. Restricted order set means it has to go through 2-3 process so that there are people to check in between and at least they are vigilant to see to it that to whom and what is the dose being prescribed, whether it is really required or whether it is not required. So when ordering a high alert medication, the provider is required to select an appropriate indication for ordering this high alert medication. The medications identified as high alert medications are labeled as such within one chart. So if you see the medication administration record, MAR sheet, so this sheet, there is a separate page where the doctors, they prescribe the medication in capital letters. So then they have to follow the standard principle of prescription, where the high alert medications will be written separately in the medication sheet, and according to that, the nurses are also aware of that. These are the high alert medication which needs to be observed, double checked, and administered to the patient, and even after administration, the patient has to be monitored for the effect of that drug. Smart infusion pumps with guardrails are used. So any high alert medication, for example, NORAD support, or maybe acrofurium, or it may be an injection, midazole, if it is needed to be given to the patient, the proper loading and the proper dispensing or administration process, it should be used. It cannot be used in a drip. It has to be used to the infusion pump so that the dose which is being prepared should not be just flowing rapidly without the notice of the nurse. So it is a way to correct it. Selected high alert medication requires independent dual clinician verification prior to the administration. So not only one single doctor will prescribe and order that medication, but there is a need by the higher authority also to recheck and sign it whether it is really required. Another strategy is like prescribing. As in a previous session, Dr. Isaac Madam has mentioned regarding the prescribing problems or errors which occurs due to the prescription. So here, do not use abbreviation when prescribing high alert medication. So you cannot use any abbreviations or shortcuts for prescribing the high alert medication. Specify the dose, route, and the rate of infusion for high alert medication prescribed. For example, if a patient has to be started on dobutamine or a dopamine, like dopamine 5 microgram per kg per minute over a minute, So what is a dilution? How much is the rate? So it has to be known to the nurse who is preparing the medication and later she is administering the medication. So the dose, route and the rate of infusion has to be mentioned in a treatment sheet so that she can follow it and she has to double check before administration. Prescribe oral liquid medication with the dose specified in milligram. So usually it is a habit of a person, it is a habit of a nurse also that it is said that 5 ml to be given. Now what is a dose prescribed? It is better that the doctors they write the dose in the milligram or whatever the dose it has to be given to the patient. And then it has to be checked with the available dose which is there with the nurse or which is there in the ward. For example, any syrup medicine which is available in the ward, it may be like a small bottle. It may have a more concentration, or it may be like pot chloride, that is potassium chloride. It needs to be checked whether what is a dose available in that, and after that whether it really requires a saturation, sorry, it requires a dilution for that before administration. So dose is very, very important. After that, the amount of that drug which is being taken from the form of liquid should be administered correctly. Do not use trialing 0 when prescribing. For example, it is set at 5.0 milligram. Simply 5 milligram is sufficient to write. Otherwise, it can create a confusion between 5.0 as 50 milligram, and a wrong medicine can be administered. Another problem which we come across is majority of the time is administration. The following particulars shall be independently counter-checked against the prescription of medication which are at the bedside by the two appropriate persons before administration. Now, due to the shortage, we usually see that only one nurse is administering the medication, but she should get counter-checked, especially for high alert medication by someone else. Maybe a junior, maybe a senior, but has to be checked, or maybe a doctor who is available in the ward can check the appropriateness of that patient who is receiving the medication and check the medicine which is needed to be administered to the patient. So what is important to check is the patient's name, patient UID number, the name and the strength of the medication, the dosage of the medication, the route of the medication, and the rate at what the medication has to be given. When you take a medicine in your hand, you have to check for the name of the medication, whether it is a pharmaceutical name or whether it is a brand name. Brand name will not have much of importance, but rather than pharmaceutical name. So you have to check for the pharmacological name or the generic name of that medicine and the dose, what it is available in your hand. Second thing, you have to check for the expiry date of that medication and the content of that medication, if it is available in the form of powder or a liquid form in an ampoule, or maybe a syrup or any fungal food. So it has to be checked properly. If at all you feel so that these medications are not in use, it needs to be returned back to the pharmacy and it should not be kept in the ward or ICU. Especially avoid ordering high alert medication verbally in case of emergency. Phone orders have to be repeated and verified. So this is related to the doctor's orders, which they give usually the verbal orders in an emergency, saying that I will be just coming within 10 minutes and you just give this medication. So you have to confirm it whether the doctor has really need to give and whether there is a need for administration of that particular high alert medication. After administration of the medication, it is necessary to monitor that the patient who is being given the medication, his vital signs are stable, the laboratory data, if at all required, the patient's response before and after the medication administration, and if at all, any antidotes which are needed for that particular drug should be kept ready. So keep all antidote and resuscitation treatment in the ward. For example, if a patient who is getting a reaction, patient may not be able to tell you that I have a reaction for Xylocaine. Maybe he is coming to the hospital for first time. So when the patient is to be administered Xylocaine, and if it is administered without any test dose, there are chances of error. But even knowing that yes, you are giving a test dose, and patient has to be given a full dose of that xylocaine for the purpose of diagnosis or maybe purpose of the local treatment. There is a need that emergency resuscitation equipment has to be kept ready because anytime the patient may collapse and may require the support to revive from the condition or from the situation which arises due to the treatment or due to the high alert medication which is given for the purpose of training. When we talk about training, all personnel shall be trained prior to handling of the high alert medication and documentation. Now, why I say that? Because any new nurse who is coming to the clinical area, she should be aware of that, what medication she needs, because everyone knows that the nurse is a person who is usually giving the medication. So it is undue advantage of the other people, those who are expert or maybe those who are working as a senior in that department, they just tell that, okay, I will just prepare this medicine and you go and administer that medicine. No, it should not be done. A proper training of a nurse, whether it is a new, whether it is a old, recurrent training of a nurse on high alert medication, how to handle, how to prepare, how to store, has to be given. And then after ensuring only the person can handle the high alert medication and the medication errors can be reduced. So staff must be trained to prevent the potential errors and enable them to respond promptly when mistake do occur. What happens if any mistake happens by the nurse? She encounters. Thinking of that, the disciplinary action or maybe the punishment arising after that, she may hide that and she may not bring it to the notice, and there we lose the patient. It may become a bigger issue to deal with by the organization or by that nurse. It may become a medical legal case. So it has to be made aware that the nurses who encounter with the issues of mistake which is occurring due to the administration has to be reported in the form of incidents report. Information. References or dilution guide should be made available in all wards. We may see that many of the wards may have a SIMS book, Medicare drug book. But SIMS drug book may not be sufficient, but it is at least sufficient for the references. And if at all, we cannot memorize all medications with their effect, beneficial effect, but it can come to us with the practice. So in all wards, it is beneficial for the newcomers. You can just refer that what is the action, reaction, and the dilution needed for the treatment of the patient or while administering the medication. Evaluation of the action is also important. Once you give the medication to the patient, monitoring is very, very important to see that whether there is any adverse drug reaction which may result into a sentinel event. So it can be prevented by keeping antidotes and important resuscitation equipment ready. These are certain, I have just presenting a chart. This says that short-acting insulin, even insulin comes as a high alert medication. You cannot give insulin instead of 10 units. If a nurse administers 10 ml, it becomes a big problem. The patient may go, a patient may die. So it is very, very important that any insulin, any injection or any medication, if it requires a dilution and it has to be given at a particular rate, it has to follow the protocol for giving or administering the medication. So here it is an example of insulin that is Atrapid, which is available in 100 units per ml, that is 1000 units per vial we are getting it. And diluent for the infusion is normal saline. It cannot be diluted in D5 or any other solution. Method of administration, it should be administered slowly, IV bolus, administer undiluted solution over 3 to 5 minutes. It can be given as a continuous IV infusion diluted with 50 units of insulin in 50 ml of normal saline. This is usually required when we come across with the patient, those who are hyperglycemic diabetic patient come with the blood sugar more than 500, 300 and they may require this uncontrolled. So definitely insulin drip is started. And when we start this insulin, rather than starting directly by the bottle, it is better to give with the infusion pump so that the required doses will be administered to prevent the errors. Remarks like related to the insulin, you can see that monitor the sign and symptoms for hypoglycemia. For if hypoglycemia occurs, stop the infusion. For conscious patient, give sweetened drink. For unconscious patient, administer D50 or glucagon. Check blood sugar if after every 15 minutes. It may cause the neurohypoglycemic and can be fatal. So overlap with the IV infusion for over 1 hour with subcutaneous insulin when converting IV infusion to the subcutaneous insulin. Second example similar to that of the insulin is of heparin, which also has adverse effect if it is given in a wrong dose, wrong form, or wrong route. And there are certain principles which need to be followed in avoiding the errors related to the high alert medication. We say that it is necessary to eliminate the possibility of errors. Don't ever allow the error to occur. So what are these possibilities? In every ward or ICU, there should be a medication formulary or drug formulary available for the reference of the nurses and the doctors. Which medications need to be prescribed by the doctor and which medicines are coming under the high alert category. So reducing the number of medications in the formulary, you cannot include all the drugs in the formulary. So there is a limit that how many drugs you can prescribe for the patient. Just for an example, I would say for a minor surgery, they give one antibiotic, one painkiller, and one antihistaminic drug. So these are the 3 drugs which are maximum given for minor surgery. Similarly, as per the case, the number of medications which need to be prescribed, but it is like a habit of a doctor that they prescribe multivitamin, vitamin C, etc., etc., etc. So they just increase the list to 14 to 15 drugs, which makes a confusion. So rather than creating a confusion, limit the medication prescription to only 2 to 5 drugs. Reducing the number of concentration and volumes to those clinically appropriate for the most. So concentration and volumes need whatever it is needed, it can be reduced. Remove or minimize high alert medication from the clinical area wherever it is possible. I can give an example of narcotic. Yeah, narcotic should not be stored in the box. It should not be easily available to anyone because narcotic, it may cause a habitual intake of some patients. Like for example, some people, they may take Fortrin very frequently because it minimizes the pain, and then it becomes a habit. So there are chances that these drugs may be stolen from the ward. So to avoid this error or the issues which occur due to the easy availability of the narcotic in the ward, it is better to just limit or minimize the availability in the ward. So there should be a policy by the organization on that. Narcotic drugs, if at all, it has to be issued. It can be issued with a proper prescription, with the double prescription of the doctors. That means the senior and the junior doctor has to write, prescribe a medication on a medication record book, and then it will be issued with the double check of the pharmacy and to the department of the ward nurse. Make error visible. Now, what do you mean by make error visible? Having 2 individuals independently checking the product or a setting is said to be that making the error visible. Now, if I alone administer medication, there are high chances that I may commit a mistake. Maybe something which is going on in my mind, maybe with the pre-motions by seeing the label, or maybe with the pre-motions by just superficially reading the name of the drug. So there is a high chance that I may commit a mistake while checking the medication with the prescription. So it is always better to have a double check so that a wrong medication is not administered to the patient. For example, IV infusion, epidural medications, insulin doses drawn up in the syringes, chemotherapy drugs, total parenteral nutrition products. So these are the few high alert medications where it is better to have a 2 individual independently checking the medication. Next is minimize the consequences or the errors. How to minimize the consequences and errors? It is just by the size of the vials or the ampoules in the patient care area to the dose commonly required. For example, if a patient is getting a particular medicine twice a day, only 2 doses should be available at the patient's locker. You cannot have 5 days medications on the patient's locker, so that the overuse of medication. So it is better to have a correct check of that how many medication, how much drug is being given to the patient, the quantity and the dose. So it will be easy to count. If you keep 2 to 3 vials, or maybe by mistake a nurse who has administered it, she forgot to document it. So again, the repeat dose may be given. So to avoid all those things, the number of ampoules or the vials, if it is limited at the patient care area, it is better to have it will help to minimize the error. Reduce the total dose of high alert medication in continuous IV drip packs. Better is to use a burette set. So usually it is a policy that for administering the IV fluid to the pediatric, we use the burette set. It is because the less dose of the amount is being prescribed or required from the pediatric. It is better to have, even when we are using the high alert medication in a drip form or the flow form, to use a burette set rather than just diluting it in a 500 ml and then marking at 250 and saying that idhar tak aa jayega to bata dunga. So it may run fast and it may cause harm to the patient. Last medication is the lookalike and sound-alike medications. Evidences show that lookalike sound-alike medications, names and packaging are one of the common problems which are contributing factors associated with the medication error. That is why it has been named as lookalike and sound-alike medication. This involves medicines that are visually similar in physical appearance, maybe packaging, maybe a naming, brand name of the medication that spells similar to that of the other drug. For example, is dopamine and dopamine. Similar sounding, isn't it? So that is a similar phonetics. Now, what is a strategy to avoid the errors which occurs due to the lookalike and sound-alike medication? First thing is procurement. When we procure the medications, when we demand the medication, first of all, minimizing the availability of multiple medicine strength. Whenever possible, avoid purchase of medicine with simple packaging and appearance. As new products of the package are introduced, compare them with the existing package. This part may not be related to the nursing directly, but it is indirectly. First, basically at the pharmacy level, and from pharmacy, when it is being dispensed to the department or the ward, it becomes the nurse's responsibility. So nurses also have to see to it that whether the package which was initially available, is that the same or there is a change in that package, and if at all there is any change, so this has to be separately stored in case of lookalike and sound-alike medicine with a proper. The other thing is related to the storage of this LASA drugs. Now the storage of the LASA drug, it is the use of Tallman lettering system. So by using the Tallman lettering system, it emphasizes differences in the medication with sound-alike name. Now Tallman lettering is nothing but it is a practice of writing part of the medication name in the uppercase. Half of the medication name can be written in the uppercase and the half can be written in the lowercase. So those medications which sound similar can be written in the lowercase or uppercase. Like for example, metformin and metoprolol. Using caution red tag notes on the cell is in order to alert the dispenser that the medicine has look-alike or sound-alike medications. So you can even store these LASA drugs by giving a color code. So look-alike can be given a different color and so sound-alike can be given a different color, so that it can be very well identified before dispensing and preparation before administration. Use of techniques such as boldface and differences to reduce the confusion associated with the use of LASA name on the label the medication storage container and is checked. Now, one more thing I would like to bring it to share with you is many of the nurses, they may have a habit of writing a medication name on the container, very nicely printed, labeling is done, and they write the quantity of that ampules or the vials which are available. Rather than writing the quantity of the vials or the ampules, she has to mention, the label has to be very, very clear. Injection, the name of the injection and the dose of the injection, in what form it is available. If it is available in 2 ml, so what is the dose contained in 1 ml? So maybe 10 milligram, 1 milligram per ml dose is available along with the experiment. So it is easy for the nurse to take or handle or to dispense that before administration. Prescribing. Now, though this is not a part of a nursing personnel, but prescribing causes the biggest error, because first of all, the person who is prescribing, maybe he is aware or he is not aware of the medication. Most of the time, these drugs have been prescribed by the doctors itself, but our nurses, they try to help them out by prescribing the medication so that the patient receive the medication. But I request all the nurses that not to prescribe the medication, because this is not in your domain. So this is the job of a doctor who has to do it, but you can always have a check over it, that whether the prescription of the medication given by the doctor is in the right form. So, place of the LASA medications in the locations separated from each other or in non-alphabetical order. Write legibly using both the brand and generic name for prescribing LASA medication. So, what is required here is generic and brand name is required when the doctor is prescribing in the proper legible handwriting if there is no software system available for that for the medication. So when the prescription should clearly specify name of the medication, dosage form, dose, and complete direction for the use. Write the diagnosis or medication's indication for use. This information helps to differentiate possible choices and illegible orders. So it is very, very important that what is the purpose of prescribing that medication should be mentioned when you are prescribing a LASA medication. If there is electronic system available in the organization, it is better to feed the system or feed the information of this LASA medication in the form of Tolman letter or boldface or maybe a color difference to reduce the confusion associated with the use of LASA medications or LASA name on the computer screen and the medication administration record too. Communicate clearly. Take your time in pronouncing the drug name whenever an oral order has to be made. So the doctor, even though the doctor who is been giving verbal orders, the nurse has to ensure by repeating the same name of that drug. So it is better to ask the recipient of the oral communication to repeat the medication name and the dose, which will minimize the verbal and telephonic errors. Another one is dispensing or supply, which is also causing the error during the dispensing of LASA medications. So identify medicines based on its name and strength and not by its appearance or location. Check the purpose of medication and the dose for the medicines dispensed. Read medication, prescription, and label carefully at all the dispensing stages, right from the pharmacy till the ward, and even if it is going near to the patient's bedside, it has to be properly labeled and stored. Commitment to final accuracy check by a qualified person before handing over the medicine to the patient or the patient's representative. This may take place at the ward level, this may take place even at the pharmacy. So it starts at the pharmacy level, that when the medicine is being dispensed by the pharmacist, there should be a double check or a qualified person again rechecks the medicine which the first person has taken out before handing over that medicine either to the patient or to the departmental nurse. So double checking should be conducted at any stage during the dispensing and supply process of the medicine. Highlighting the changes in the medication appearance to the patient upon dispensing. For example, they have to mention it that before handing over the medicine, like in the form of syrup, if it is contaminated, like there may be a clumsy fungal growth inside that syrup. It should be first checked by the person who is dispensing, and it has to be educated or it has to be communicated to the patient or to the wardens that it has to be checked before you administer. Usually, this occurs during the when the medicines in the form of syrup is being given to the patient. So, without checking, if you just give it to the patient, it may cause harm. Now, while administering the medication, read carefully the medication label each time during the medication administration process. Now, what happens? We as a nurses, we are very confident while giving the medication. कल भी हमने ये इसी में से medicine देके दिया था, and I know that this is the same strip. So, without checking, we usually administer the medication. So, it should not happen. It is your prime responsibility and duty to check it properly whether you have given the medication of the same strip, but it has to be checked again and again so that by mistake, if it is changed or if it is being replaced, we don't know. So that may cause error. Perform the double check to check actual medicine and prepare it with the prescription and label. So check the purpose of medication and the dose prior to the administration. Next comes monitoring. So monitor new drugs added to the hospital formulary as they are released and provided guidelines to these new drugs. Monitoring of the new drugs. So any new drug which is added to the hospital formulary, when it is been administered to the patient, there are certain released guidelines which have been provided. You have to check for it. What are the action, reaction, benefit of that particular drug? So the patient has to be monitored who may receive any type of drug, especially if a patient who has received a wrong medication as a result of LASA medication error, the patient need to be monitored, and if at all required and available, the antidote for that medication can be given for the correction. So patient, it is a hospital acquired event, incidents. Information. Now, what type of information is required? Update the healthcare professionals of changes on the list of LASA and confusing drug name. So, if there is any addition, deletion in the drug formulary, it has to be updated to the healthcare professionals on the list added or deleted, or if there is any confusion related to the drug name. Another issue is that another thing is that you can provide education on LASA medication to the healthcare professionals at the time of orientation as a part of continuing education. Now, the most important when the patients are going home, the discharge advice on the basis of treatment regime. So, patient education, information to the patient on the change in the medication appearance has to be given. Educate the patient and their caregivers to alert healthcare providers whenever a medication appears to vary from what it is usually taken to administer. So when the patient is going home, the patient has to continue on some medication. So what is required? The patient education is required. The information needs to be given to the patient that which medicine has to be given. Otherwise, it is a usual tendency of a person, they are not qualified in medication. So they are the lay people, they don't know about medication. The red packet mein ka do goli, lal goli, pila goli. They identify medication based on the color codes or the shape of the tablet or maybe the color of the strip, and it may arise in medication error or adverse effect of that drug. So encourage patients and their caregivers to learn the name of their medications. Or if at all the person is illiterate, you can write and label over the strip and can be given so that it should be given in their own language or maybe a national language, Hindi or Marathi can be given. It should be specifically denoting that whether it is a half tablet, 1/4, or it is a full one tablet. Now, another important thing is that once the medication is administered, you are monitoring the evaluation of any medication errors, whether it is related to the LASA medication, it has to be evaluated. Now, after knowing what are the medications, high risk medications, medication management is very, very important. So, according to the Joint Commission on Accreditation of the Healthcare Organization, medication management includes ensuring that self-administration of medications are safely and accurately administered. The patients and the caregivers must be given information about what medications they are taking, as well as the description of the method of administration. It is very important to tell whether it has to be taken before breakfast, after breakfast, or early in the morning. Expected action and adverse reaction can be explained, and the method of monitoring the side effects also need to be told. As well as the follow-up should be used to monitor the treatment at the ward level when the patient is hospitalized, and in post-discharge when the patient goes with the treatment and has to continue the treatment at home. What does this medication management mean? Medication management means medication adherence. Now, this is a system level definition. Medication reconciliation. This is also a system level definition. We are going to see this in detail. Optimal medication therapy. This is a clinical level definition, and healthcare literacy is a patient level definition. So, under these four categories, the medication management is discussed. Medication reconciling is nothing but it is a medication error, and the patient confusion most commonly occur during the care transition, maybe during the time of admission, transfer, or discharge from the healthcare facility. For example, if a patient who is diabetic and he is on tablet metformin, and if he comes to the hospital, he may not bring medication, but it is the prime responsibility of a nurse, casualty nurse, to ask whether the patient is on any medication. If at all he is available or he knows the name, it has to be mentioned in the chart that the patient is on metformin. Before, or if at all, any medications which are given at the first aid level, as a first aid level, it has to be mentioned, and after that only the patient needs to be transferred. We see the discharge chart or discharge summary usually that the treatment given in the hospital and the treatment advised at the time of discharge. These two things are separate and it is mentioned in the card. So, medication reconciliation is nothing but it has to be mentioned and know that whether there is any confusion that medication which is need to be taken or continued even after the discharge, or maybe must have been taken before admission. So, medication reconciliation in the process of comparing a patient's medication order to all of the medications that the patient has been taking. This reconciliation is done to avoid the medication error, such as omission or duplication of the medication, dosaging errors, and the drug interaction. Sometimes this is very, very important. Usually, when the patient comes with a casualty, that there should not be any drug interaction with the previous medication, which the patient has already taken, or there should not be a repetition of the dose, duplication of the dose. Reconciliation of the medication also needs to be done during the hospital administration, admission, discharge, and follow-up to make certain that all the patients with their providers know what the patient's medications are at the time of transition. Optimal medication therapy. Now, optimal medication therapy, it is a clinician definition, clinician-based definition, and it is a process which includes prescribing safe, effective, and efficient medication for a specific patient. So this is very, very important that prescribing safe, effective and efficient medication for a specific patient. So this is being prescribed for optimization of the drug therapy, which is crucial step to help patients management in their medication. The appropriate drugs and appropriate dosage should be prescribed. Medication type, maybe your aspirin, beta blocker, or aggressive reperfusion therapy have improved the area of medication management by reducing 1-year mortality after the myocardial infarction. So these are some examples. Monitoring the dose, drugs such as ACE inhibitors or beta-energetic adrenergic blocking agent are often not prescribed in the optimal doses due to their need to be titrated. Now, medication management is best accomplished by the team of clinicians. Now, when it is said to be a team of clinicians, it is known that the physician, the nurses, the physician assistant, the nurse practitioners, they are involved in medication management, where the appropriate care or the knowledge of the expertise is used for optimization of the medication therapy, decision, education, or educating the patient, implementing and monitoring the medication therapy, enhancing the adherence and measure and achieve quality clinical outcome. So team includes physician, nurses, pharmacists, but it is usually found that anything which goes wrong is blamed for the nurses. But a nurse who is accountable for administering the medication can be vigilant throughout the process of medication administration, right from the prescription, transcription, dispensing, and preparation and administering and documentation. The nurse is a person who can be vigilant to identify the error and prevent the patient developing any harm during the stay in the hospital or even at the time of discharge. Medication management policy is usually done for facilitating and maintain a safe and competent medication administration or medication treatment for the medication therapy for the patient. And it is based on the best practices and the care process of the resident that includes recognition of the problem, the need of the problem, the assessment, diagnosis, medication administration, management, monitoring, and revising the individual person-centered approach to care, as well as documentation consistent with the standard of medication management and administration standards. The objective of this policy is to promote safe and accurate medication management for each individual resident, to ensure system for accurate process of assessment, planning, implementation, and monitoring and evaluation, as well as staff competency to promote quality of care, increase resident safety, and safeguard against the abuse. You will usually come across with certain definitions like acquiring medication. Acquiring medication is nothing but it is a process by which the facility requests and obtains a medication. Adverse consequences. It is a broad term referred to unwanted, uncomfortable, or dangerous effect that a drug may have, such as impairment or decline in an individual's mental or physical condition or functional or psychosocial status. Adverse drug event is an injury resulting from medical intervention related to a drug. Adverse drug reaction is a response to the drug which is noxious and unintended, which occurs at dosages normally used in man for prophylaxis, diagnosis, or therapeutic purpose, and for the modification of the physiological function. It can be a hormone, it can be an anesthetic drug. The noxious effect of it is termed as adverse drug reaction. Whereas medication error, you will find that is a preventable event that may cause to be lead to inappropriate medication use or patient harm while the medication is in control of healthcare professional, patient, or consumer. Now, with this, I say that I conclude that medication or safe administration of high alert medications is part of a medication management. There are many things which is related to the medication management, but I have focused today only on the high alert medication. So high alert medication carries a higher risk of developing dangerous or developing harm to the patient, which may result into the adverse drug reaction and event, and resulting into the sentinel event where the patient may lose his life. So it is our prime responsibility as a nursing staff that we should be vigilant by providing care to the patient during his stay in the hospital, and at the time of discharge, appropriate and adequate information need to be given to the patient on medication and the way of medication, dosage, administration, everything. So I would say that this small topic may help you to improve your knowledge so that we are alert by handling the medication and administering the medication to the patient. Thank you.
Thank you so much, madam, for sharing your thoughts on importance of medication safety. Moving further, I now welcome our next speaker, Dr. Mrs. Savia Fernandez. Madam has completed her BSc in the year 2002, MSc in 2010, and PhD nursing from MGM IHS Kamote, Navi Mumbai. I hope I'm audible. Hello.
Yes, you are.
Yes. Madam has over about 14 years of experience in various sectors like clinical setting, education, and nursing administration. Madam has played active part in JCI and NABH standards accreditation process in the MGM Hospital, Vashi. Ma'am has worked in various places like MGM College of Nursing, Kamote, as a tutor, as a nurse, as assistant matron in MGM Hospital, Vashi, and currently working as nursing superintendent in MGM Hospital, Vashi. Ma'am will share her thoughts on surgical safety. Moving further, I hand it over to Dr. Mrs. Savia Fernandez. Thank you.
Thank you, Priyanka. I'll just open up my slides. Thank you. Good morning, everyone. I hope I'm audible. Am I? Hello?
Yes, ma'am.
Yeah.
You're audible, ma'am.
Fine. Good morning, everyone. So today we'll be discussing on safe surgery. Okay. This, I think my screen, is it very clear or how is it for you?
It's clear, ma'am.
Okay, so
It's visible.
all right. So across the world, we had a new discussion which is going on safe surgery. There are various companies who have got together and they have come up with innovative models to expand the safe surgical care to people. Because across the world, it has been noticed that many of the population in developing countries and underdeveloped countries have no access to safe surgery. So this is the what you can say is the main crux of today's world, that we have to provide a safe and effective surgical care and management to patients across the world. So what does safe surgery basically mean? So it just doesn't mean only your surgical items. It involves various other systems, as what is being depicted on the screen. You have your anesthesia, you have a trained anesthetist, a surgeon, you may have a surgical ICU or a post-anesthesia care ICU, you need sterile instruments, you have to ensure that you have your lights and electricity power supply backup. You require your adequate materials and equipment, could be varied right from gauze piece to your high-end instruments to robotic surgeries which are available now. You need to follow this WHO Safe Surgical Checklist. We'll see much more in detail of this. Plus, you need to have your various labs, your tests, your diagnostics, which are done, which will give you a clear-cut idea as why you need to go for surgery. Okay, so these are the various aspects. We'll basically look into our safe surgical checklist formats. All right, so when we define safe surgery, we don't just mean that the surgery is being performed by a skilled or an experienced surgeon, but it also encapsulates the whole team, right, the whole surgical system. It is considered safe from start to finish, that is right from the admitting of the patient till all the way through their discharge process. So going to certain facts, one of the key findings of the 2015 Lancet study was that 5 billion, I'm so sorry, just let me go back. Okay, there are some billion people who do not have access to safe or affordable surgical and anesthesia care, which is needed. So access is worst, as what I had said, in low income and low middle income countries, where 9 out of 10 people cannot access basic surgical care. So if you just see that, the kind of care that we need to provide for our patients is very debilitating, and we need to ensure that this number goes a bit low. 9 out of 10 is almost 90% of those people who are not getting across safe surgical care. Why safe surgery is important? Basically, it's often the only therapy that can elevate disabilities and reduce the risks of death from common conditions. So when you have no other alternative for you other than going for a surgery, I think that becomes the utmost important task to be carried out. And here again, every year there are millions of people who undergo surgical treatment and surgical interventions, and which account for an estimated 13% of the world's total disability adjusted life years. That means because of a wrong surgery or an incorrect performed surgery, or because of the complications related to surgery, there are patients who are in who face kind of a disability for their lifetime. So next, let's just have a brief on the unsafe surgery care results. It's reported that the crude mortality rate after a major surgery is somewhere varies from 0.5 to 5%. Complications after inpatient operations occur in up to 25% of patients. And in developed or industrialized countries, nearly half of all the adverse events in hospitalized patients are related to surgical care, or at least half of the surgeries in which surgery led to harm are constantly, in which they are preventable. And mortality from general anesthesia alone is reported to be as high as 1 in 150 in some parts of sub-Saharan Africa. So these are areas wherein these studies were conducted, and they came up with these figures. So in relation to this, WHO has taken a very, very important step, and it has taken the message globally that you need to have a global and a regional initiative to address the surgical safety. And this came up from this WHO's second Global Patient Safety Challenge, wherein it was titled, or the theme was appropriately given as Safe Surgery Saves Lives. So to improve the safety of surgical care around the world, WHO defined a core set of safety standards, and it came up with what we are, in most of the hospitals, what we practice now is the WHO Surgical Safety Checklist. So what does this surgical safety checklist mainly incorporate? It was defined or developed after an extensive consultation aiming to decrease errors, decrease adverse events, and to increase the teamwork and communication during surgery. So this 19-item checklist has gone on to show that there is a significant reduction in both morbidity and mortality, and now is used by a majority of surgical providers across the world. So this is what the surgical safety checklist looks like. So you have it divided into 3 sections. One is before induction of anesthesia, before your skin incision, and before patient leaves your operating room. Now with NABH coming in and JCI standards are also focusing in that this safety checklist has to be a primary important tool for all surgeries happening in hospitals which are accredited either by the NABH or the JCI. So this is a part of your surgical process. So we shall be looking at each of these sections one by one. So basically the components of the surgical safety checklist has 3 phases, that what we have just seen. It has something called a sign-in, that is before the induction of anesthesia. We have before the incision of the skin, that is called as time-out, and before the patient leaves the operating room, that is your sign-out. So in each of this phase, a checklist coordinator must confirm that the surgery team has completed the listed tasks before they start with the process. So your checklist coordinator could be your circulating nurse, or it could be any other nurse assistant who is present in the operation theater, who knows about the surgery, what are the processes, and is very keen, and also a person who can take a stand and say if there is a mismatch, then she can also halt the procedure and say that something is a miss. We need to go back through all the safety checklists again and then only proceed. Okay. So how to run this checklist in detail? That's something that we are going to see now. So again, we have seen it's a sign-in, time-out, and sign-out. So what does the sign-in basically consist of? So I have just given you a section of the checklist which is there before sign-in. So it takes place in the theater reception, that is before your patient could come into your actual operation theater. So you could have an area wherein this sign-in is being done. And here we see these following areas, that is you are safe to go back to the theater. It is performed by a pre-op nurse or a circulatory nurse along with the anesthetist. And basically look into your pre-procedure preparation. So you have to ensure that you have your relevant lab tests, your implants, your surgical items, everything which are in place. You should also assess for your DVT prophylaxis assessment done. So for DVT prophylaxis, again, there is a standardized tool which can be used at the time of admission, wherein your floor duty doctor could do the pre-assessment of a DVT prophylaxis, or which can also be done by an anesthetist when he comes for a pre-assessment checkup. And you just check if you need any warmers in the unit, because if the temperature is going to be really very cold and you need to have warming up devices, ensure that your warming up devices are in place in the operation theater before you begin. Okay, so let's look at various aspects of this sign-in checklist. So here first we have to see that the patient identity has been confirmed. So identity, site, procedure, consent. We see the site is marked, anesthesia safety checklist completed. We have a pulse oximeter or a cardiac monitoring in place, whether the patient has any allergy or difficult airway or respiration, and things like that. So let's see each one in detail. First, let's see for the patient identification. Now, we all know that patient identification is very important, and both the NABH and JCI clearly instructs all the hospitals to have 2 patient identifiers that you identify and depict into your policy. So NABH clearly says that every patient who walks into your hospital should have a unique hospital identification number other than your IP number or an OP number, plus your complete patient name in which is being used during your registration. So for during identification, you can have your own process wherein you have identified your patient identifiers. Basically, you can go ahead with the UHID number or the unique hospital ID number and the patient's full name. So these could be your patient identification details. Please do not use your bed numbers for identification. or saying that so and so patient is admitted under so and so consultant as an identification method, because these are very frugal and could lead to errors. So if you have a uniform process across in your hospital, this can be utilized across, and all of your team members or your staff could be trained in those policies and procedures, so they are also knowledgeable about how to go about it. Okay, so if you look up at studies, it has been found that 7,000 out of 7,600 wrong patient events reported by the 181 healthcare organizations over 32 months. So you can imagine the amount of errors which are caused only because of incorrect patient identifications. And according to an analysis performed by a research firm in Philadelphia, there were 87% of misidentification errors during patient encounters, and 13% occurred during patient registration and scheduling. So thankfully, 91% of these errors were caught before the patients were harmed. So if you look at the stats, if 87 is not a very small number, and these are countries who do show or report their error data or their audit data, whereas a country like India, we are not so confident to report our data, or we do not highlight our key stats for the public to learn from our mistakes. But that's the main cause in which most of our data is not being published, or we are not aware of what is happening in India. But across the world, if you have such kind of errors happening, and it's a big risk to patients, and they are at the end of the day, they are the ones who are on the table. So we need to primarily take this as a very serious notification, and ensure that the patient identification is carried out as a priority across hospital wherever the patient is being shifted. So basically, we look into two patient identification parameters. That could be an UHID number or the patient's name in detail. Next, we go look into the identification of the correct site. So for site marking, we have in our hospital, we follow this mark. We have an arrow mark towards the incision site, and a site mark must correlate with your patient's interpretation. So supposing if your patient is saying, I'm having my left knee pain, so I know that my left knee is the place where I'm supposed to be operating on. So always keep, if your patient is conscious and oriented, keep your patient in loop during your site marking process. Ensure that it has been clearly documented into your medical record. Ensure your consent, which is being taken by the surgeon or his surgical team members, has clearly identified the site and it has been marked, and it both matches what is written into your consent paper as well as what is there physically or present on the patient. Ensure this has also been documented in your physician orders, and it is also coinciding with what your radiographic studies have been showing. So you can have your X-ray, which clearly shows I have, left knee fracture, or I have to operate on my left knee. So we have something called as the surgical site marking pens, which are sterile, which can be used for marking the site. And there are areas, there are countries across the world which they are using this sticker, where it's a two-color sticker which is having a green and a white color base. So this sticker also is being used in some of the countries and some hospitals, which ensure that you depict your correct site. So when you mark the site, you have a uniform policy that you say, okay, I'll be marking with an arrow. Ensure that nobody follows a tick mark format or a crisscross format or a circle format with a dot. So it should be uniform across the organization. Ensure that this marker pen which has been used stays till your patient is wheeled in for surgery, till the patient is being draped and prepped up, so the surgical mark doesn't vanish. Ensure that when you are giving a pre-op wash to your patient, ensure that mark doesn't vanish, so it stays there, and it can be the key reason why you are identifying your patient before taking up for surgery. Okay, so that's important. So you have mainly is your identification of your correct site. Next is you can have your policy for site marking. That's what I basically discussed on. So for all procedures involving laterality, that is you are on both the sides of your body, levels or multiple structures. So the intended procedure site is marked. So you exactly depict which is the area where you are going to do your surgery on. So here you should take in consideration the laterality, the surface, whether it's a flexor or an extensor, the level, that's especially in spine cases, or you can have your specific digits or region to be treated, like you can have your right finger, maybe my forefinger or my right thumb. So here, importantly, you should have the patient or the legal representative shall participate in the procedure during site marking. So you and the patient are in consensus as to which is the site that has to be marked, and it has been marked correctly. So here there are certain areas for site marking. So like site marking should include, but is not limited to the following. Any procedure on an extremity should be marked. Multiple structures such as fingers and toes. Spinal procedure we have already spoken about. Unilateral procedures such as on the eyes, ears, sinuses, mouth, face or neck. Thoracotomies and thoracoscopies, procedures involving the joints, inguinal hernia repairs, unilateral procedures involving the breast, uterus, ureters, your kidneys, ovaries and testicles, your chest tubes. So any procedure that relies on radiological study for site designation, you should ensure that the X-ray, the CT film or the MRI film is present in the OT theater or the operation theater. And you should also be using site marking for your peri and post-operative acute and chronic pain-related anesthesia blocks. So special considerations is, for procedures that involve laterality of organs, but where the incision or approaches may be from the midline or from a natural orifice, the site is marked and the laterality is noted. So if you have to operate and you need to, like you are going to operate somewhere on your left side of your brain and your incision requires something to be taken from below the earlobe, or that's where the surgeon has pointed out. So below the earlobe is the site which has to be marked. Okay. So alternative, certain areas wherein you cannot do the site marking, or it has some obstruction, or there is a wound wherein you cannot mark the site. So there are alternative processes for site marking. You can either use, like for cases in which it is technically or anatomically impossible or impractical to mark the site. So you can either have another wristband which is being placed, like supposing I'm going to operate on my left arm, then I will use a kind of a wristband which indicates that this is the site or this is the arm where I need to operate on. Or you could have another figure, like we in our hospitals, we have an anatomical figure which points out that if in cases where I'm not able to mark the site on the person, I can mark it on that anatomical diagram, which indicates clearly where the surgical incision will happen. All right, so sometimes when examples include your mucosal surfaces, your perineum, sometimes in premature infants, right? So because sometimes there is an obstruction, like point of view from the parents saying that this may cause a tattoo or the ink may sink in because the child is the skin is very tender and fragile. So in this kind of cases, you can have another anatomical figure where you can mark the site, or you can have another band which is being placed, depends upon your hospital policy or what is the best procedure you can choose for your hospital. So for minimal access procedure, wherein where that that intend to treat or lateralize internal organ, you can mark at the site of the incision. All right, or in case if you have a sterile draping, like you have already done a dressing on that on the wound site, you can mark on the dressing itself. Like for teeth, where you are going to what you can say, have an extraction of tooth or any procedures for the dental thing, you can either have a dental diagram which will indicate either your incisors or molars have to be removed or some procedures happening there, or you can have your dental radiographs which are available, and you can mark on those dental radiographs the site where you're going to operate. Right, so basically for scheduled operative or invasive procedures, you can clearly write on the form, and the form should be legible, And if it is illegible that you cannot make out whether there are short forms being used, please do not use such forms because that can lead to errors. So best words is to use right, R-I-G-H-T, and left as L-E-F-T, which has to be completely spelled out. So if you are going to write on your form saying that it's R-D-T-K-R, it is better to write R-I-G-H-T, right total knee replacement. So now the JCI has clearly demarcated or put up a process in place saying that there should be no short forms used in documents which are being accessed by the patients. Like now, if you say a consent form is being read and being signed by the patient and the patient's party. So these consent forms should absolutely have no abbreviations, even though they are standardized abbreviations. You know, you may say RP is commonly used, R with a circle is commonly used across the world. So, but now there has been a policy, or it has been identified and felt the need that any procedures or any consent forms which have been signed by the patient party and the patient has to have absolutely no abbreviations. So you have your consent clearly demarcating the diagnosis or your plan of procedure should be written in complete sentences and in complete words, right? So will not be accepted. So then the physician or your physician's team shall discuss the operative or invasive procedure with the patient before anesthesia or moderate sedation, so that the patient is conscious enough to make a decision and knows exactly what is being discussed about the case and about the surgery. So contraindications is, again, sometimes when we have an emergency surgery and we cannot delay because of site marking or pre-operative checks and needs to be urgently taken into OT, well, that's kind of a contraindication where site marking cannot happen. Sometimes for teeth and mucous membranes, yes, because on the patient we will not be able to mark the site, so we use another form, like you can have the diagnostic films, or you can have a diagram where you can mark the sites. Okay. Yes, next we go look into the consent. Consent matters, yes, without the patient's consent or the patient's team's or patient's relatives or the surrogate who's signing the consent, without their undertaking, we cannot go ahead with surgery. Certain few points to be taken into consideration during consent is it should be voluntary agreement or permission from the patient. You can always say, yes, a patient came to me to the OPD, I have discussed the procedure, I have written everything which is there, but before going to the operation theater, your consent format has to be explained with the contraindications and certain other parameters which will be discussed in the next slide. And then only the patient's consent has to be taken. So ensure that the patient is in the know-how, the patient's relative or the team who is there present, the patient knows what procedure, what are the contraindications, indications, etc. are aware, and then only we can go ahead with the consent. So no doctor can examine an individual on the instance of an employer saying that, okay, I have somebody who's saying that I need to examine the patient until the patient gives you a consent. So consent is often viewed as the single most ethically important aspect of medical ethics. So all of medical ethics is but a footnote to informed consent. So that's what is being declared. So without consent, you cannot go ahead with any procedure. So a small or can say a thing for us to remember before we take in consent. So think brain. So brain is what are the benefits? How will this thing help them out? What are the risks? What are the alternatives? Has to be clearly explained. If there is a surgery, do I have any other non-invasive methods? Can I go in for a medical management? What does my intuition tell me? What is the gut feeling? Should I go for a course of action, or do I need a second opinion, or how does my team feel? And what if I do nothing right now? Like if I can keep it on a hold for a day or two and then take a call, will that affect the prognosis of the patient? Will it affect him in a very difficult way? This is something that we have to look at. So the common misunderstandings that we encounter during consents are consent that is not fully informed is not informed consent. So every time ensure that a consent is fully taken. And it's just not a piece of paper, it has to be a process. So right from the time of admission to your time of your surgery, everything has been explained and clearly understood by the patient. Consenting a patient is impossible. Do not keep this in mind until unless you explain to the patient clearly and the patient knows exactly what is going to happen. He will always be ready to give you the consent. And the purpose of the informed consent is to protect the patient. It is actually to protect the doctor. Okay, so until you have your paperwork in place and you have clearly explained and both the patient party and the surgical team is in consensus to go ahead with surgery, then it's a good thing. So personally, you have to ensure that any risk is clearly explained and the consent is taken by the patient. Right, so next we have seen the consent procedure. Next, we have also seen the site which is marked. Let's go in for the anesthesia safety checklist. So there is a pre-anesthetic checkup which is mandatory for all patients going in for a surgical procedure. So ensure that your anesthetist comes on your floor, sees the patient, ensures the PAC is being filled. There is like surgery fitness which is being taken either from the physician or cardiologist as per the suggestion of the surgeon and the anesthetist, and then only things are proceeded. It will be very a wrong process if you say my anesthetist will see my patient in my pre-operative room. Now, this goes on saying that in case if the anesthetist has already briefed up the patient and seen a little bit of paperwork is remaining, or maybe just fine tuning is remaining in the paperwork, well, that could be done in the pre-op room. But the kind of anesthesia to be given, what are the anesthesia risks, whether the patient assessment is being done by the anesthetist is primarily important and has to be done at the patient's bedside, whether it's in the ICU, in the wards, or in any of the rooms. So there's no excuse on that the patient should not be seen by an anesthetist before the PAC. Rather, the PAC has to be done 1 day prior. Any follow-ups or investigations pending has to be checked on, and on the day of surgery, before the patient is being taken, there has to be a follow-up by the anesthetist to ensure that the patient is fit for the procedure. Okay, so some points which we can keep in mind for during can say is for intubation is, there is, in case if you have a mouth which is opening less than 3 centimeters, there is limitation of neck movements, there is micropneia, that is, you have your jaw, lower jaw that is not developed. Macroglossia, you could have a large tongue. There is protrusion of teeth, short-necked or morbid obesity. So as when we are doing our nursing assessment, though this is to be done by the anesthetist, when we do our nursing assessment and we know this patient is going for surgery, and these are the points that has to be kept in mind. Better to note it down in your nurse's note so that if when your anesthetist is coming on board, you can clearly explain and further also be in a position to make the patient understand if it's going to be a difficult procedure because of these indications. Next is your airway examination. Ensure that your patient opens your mouth normally, able to visualize, at least the surgeon or the anesthetist is able to visualize at least a part of the uvula and the tonsillar pillars, the normal chin length, and the normal neck flexion and extension is possible. So when you do an airway examination, look for a small or recessed chin, inability to open mouth, again inability to visualize your tonsils, you have your high arched palate or tonsillar hypertrophy. So these are the various points that you have to keep in mind. Some factors which can predispose a patient to aspiration could be an emergency surgery, an inadequate anesthesia, could be an abdominal pathology, obesity, opioid medication, neurological deficit, lithotomy position, or it could have a difficult intubation. There would be no reflux, is that. So when you're preparing for anesthesia, ensure that the patient is continuing the current medications or treatment of the coexisting diseases. It is the responsibility of the anesthesiologist to instruct patients regarding which medications to be taken and which to hold pre-operatively. Now, if we have to see what is the nurse's role here, is during the time of admission, it is always good enough to ensure that the patients come with their home medications or they know what medications they are on, as what Padmaja had discussed in the previous topic. Medication reconciliation is very, very important to understand. There is no duplication of medicines. The patient's medicines are with you. During your anesthetist rounds, it is clear to be, it's very important to be very clear on what medicines have to be continued on the day of surgery or after the surgery. So with the anesthetist, it is also our lookout to see the medicines are proper, which has to be discontinued is being sent back to the patient's relatives, what has to be continued is there with you on board. So here, as a nurse, you have to ensure that patients have been instructed to take medicines with small sips of water, even if they are fasting, or you could convert those medicines into an IV therapy, wherein the medicines can be given. So to be continued as per the instructions of the anesthetist, obviously, should be all your antihypertensives, your cardiac medications, antidepressants, your thyroid medications, and other medications which are on board. So this in lieu with the anesthetist, of course. Going next to is our timeout procedure. So perform a timeout with all the relevant members of your procedure team who actively have to communicate during your timeout. So the team members have to agree at a minimum on correct patient identity and your correct site of procedure. So when the same patient has to do two or more procedures, like you have a change of surgeons, then a second timeout needs to be done before starting of the second procedure. And important is you need to document the completion of your timeouts. So for timeout, for timeout, you have to have the entire surgical team. Your team introductions have to happen. That is, the surgeon has to introduce himself, the anesthetist, as part of your surgical team. You could have another 2 surgeons with you or team members helping them out. If you have, like in case when we have implants, we have some of the company people coming into the operation theater with their implants who will assist the surgeon for the procedure. So also those people need to introduce themselves. Then you have to have all your pharmaceuticals, that is your antibiotics and other medicines on board. You have to understand what is your risk of blood loss, ensure that the blood is available to your blood storage unit or your blood bank is already reserved and kept in case if required, has to be issued, so it's handy for you. Ensure that your patient's positioning, your padding of your patient, your straps, changes in position, equipment, everything is in place. For radiology, ensure that all your X-rays, your MRIs, or whatever radiological things were being finalized are already there with you with the reports. Check for equipments like your implants, anything special which will be required, right? That has to be ready in your operation theater. Check for any fire risk assessment. Can look in for your alcohol-based rep, see whether your OT lights are in working condition, your UPS backup is available, and ensure if it's going to be a 60 minutes procedure to check or more than 60 minutes procedure which is required. Okay. So this is what is the checklist stating here. So all are verbally confirming the patient site procedure. You anticipate for any critical events, all right, any unexpected steps or operative procedures, durations, everything. Anesthesia team reconfirms if there are any specific concerns, like it will be a difficult intubation, or do I need to keep a tracheostomy set ready, or do I need to have any other equipment available with me, like a ventilator in case a patient condition deteriorates. And nursing team reviews has to see their sterility, including your indicator strips, whether all your sets, your ETO items or your STARAD items are clearly indicating their expiry date is clear and they have been confirmed. And in case if there are any equipment issues or concerns, do I have a backup set available with me in case any of the items are having a breakdown? Do I have something else also available? Whether your antibiotic prophylaxis has been given within the last 60 minutes. Now, we'll be talking about that in detail. So coming to your antimicrobial stewardship program, this is a big highlight by both the NABH and JCI, who keep on insisting that your antimicrobial stewardship program for surgical prophylaxis has to be strengthened and it has to be worked on time and again. So what basically happens in this is your microbiology team or your microbiologist who gets these samples of your surgical site or who knows the current existing infections or infectious microorganisms in your hospital will define the antibiogram in consultation with your surgeons to ensure what kind of antibiotics could be given to patients and in what stages. Like in case if I do test a patient and find that my first line antibiotics are not in use and patient condition has been very deteriorating and he has already been started on a second or a third line of antibiotics, like could be an meropenem or could be to that level of antibiotics, then it has to be ensured that over a period of a year your antibiogram details are collected. There is to be a meeting wherein these incidences of patients' conditions getting deteriorated is being discussed. The various types of antibiotics being used currently in your hospital is being discussed, and a program is being designed with the inclusion of your various stakeholders like your surgeons, your physicians, your microbiologist team or an infectious disease consultant, your intensivist. They all pull up together all this information and they come up with your antibiogram. And based on this antibiogram, you are giving them a list of antibiotics which can be administered to the patient before the incision. So the timeline is before 60 minutes of the incision, this antibiotics first dose has to be given. So, and then as per this stewardship, antimicrobial stewardship program, we have to follow up all your surgical cases for up to 30 days of the procedure. And in case when you are using your implants, like for your TKR, THR or whatever, when you use implants, it has to be, the case has to be followed up till a year to see if there is any surgical site infection present for the patient. So this is the recommendation by CDC that this you need to formulate your antimicrobial stewardship program in your hospital, especially for your surgical prophylaxis. So there are leading causes of nosocomial infections after surgery, accounting to almost 40%. Could be because the first dose of antibiotic was not in place, or you have not prescribed the correct antibiotic for your patient, or you have not done a kind of, your pre-operative checkup did not see to it that your patient was at risk of getting an infection and so on and so forth. So there are various instances that has to be, or various criteria that have to be met before you come up with your antimicrobial stewardship program, and that's very, very important. So here if you see, if your patient gets a surgical site infection, the cost of care goes up to threefold higher than that of surgical patients without infection. So the patient who is having major surgeries, could be a CABG, could be a nephrectomy, could be a craniotomy, in case develops a surgical site infection, then the kind of antibiotics that have to be used, the length of stay increases in the hospital. With this, the cost goes up to threefold higher than for normal other cases. So other than that, your quality of life again gets compromised. You see, there is an account of around 3.7 million excess hospital days and more than 1.6 billion excess cost manually. So that's a huge number, and which can be reduced only basically if you take care of your surgical site infections, right? So, and furthermore, if patients who develop surgical site infections are 5 times more likely to be readmitted. See, supposing if you have a patient whose wound is not healing, there could be gaping of wound, there could be again pus formation, scar formation, could be leading to other signs and symptoms, like patient may even land up with sepsis. So you have your ICU stay going up, you have your patient comorbidities getting developed with other factors like your kidney injury and so on and so forth. So the chances of patient getting readmitted and staying in the hospital will be much higher. So what do we do? So for your surgical prophylaxis approach, so if you see that if you test your patients who are going for a surgery, and if you test for them for MRSA, so ensure that if they are tested for positive, you have your mupirocin ointment in place, and that is applied with a combination of chlorhexidine body wash. That's what the CDC guidelines are indicating right now. So mechanical bowel preparation alone without administration of oral antibiotics is not used in adult patients undergoing elective colorectal surgery. Again, it depends upon your surgical team who is going to tell you what are the pre-operative instructions. Patients who are undergoing any surgical procedure, this is important, is you do not need to shave the site, you need to use a clipper. Now, clipper is important because it clips off your hair almost a point few millimeters above your skin surface. So when your surgeons are using the high-end glasses, when they see the skin incision, they get all crisscross marks for the skin, and you are already exposing your skin to your organisms much before the patient is being draped or prepped for surgery. So clipping is a very good process, which can be used especially for major surgeries when you are going. So shaving is strongly discouraged at all times. Shaving is mainly done by class 4 workers, and they wouldn't even know the benefit of how a site or surgical site has to be prepared. So you are risking your patient's condition just even before the surgery could happen. So ensure that you do not do any shaving. Go ahead with clipping. That's quite important and quite well, can say, taken up these days. So here you have to ensure your surgical antibiotic prophylaxis is administered before your surgical incision, preferably 60 to 120 minutes. It's preferably now 60 minutes before incision. And important is you have to consider your half-life of the antibiotic. So if your half-life is very short, ensure that your second dose is given during intra-op of surgery, especially if you have surgeries which are going for more than 4 to 5 hours. Surgical hand preparation is very important. You use a suitable antimicrobial soap to disinfect your hands, or before you scrub for your surgery, and ensure that your alcohol-based antiseptic solutions are based on chlorhexidine, which are used for surgical skin preparations. So there are certain recommendations which can help surgeons incorporate the best evidence-based guidelines, like your prophylactic antibiotics could be discontinued at the end of the procedure. Right. In addition, the prolonged use, even if for 24 hours, does not help relevant surgical sites. So sometimes we have seen that antibiotics go on for days at length, 5 days, 7 days, when they have absolutely no indications for the patient. And topical antibiotics are not indicated in the era of prophylactic systemic antibiotic therapy. So, and importantly is your limited fixed courses of antibiotics are sufficient. So you can have just 1 day course of antibiotic or max 2 or 3 days course. This all can be discussed and finalized in your antimicrobial stewardship program, and any doubts or things can be clarified by the microbiologist with her data, kind of usage, kind of organisms, and both the resistant and the sensitive organism data, and she can present it to your clinicians or your surgical team. So last we come up to your sign out procedures. So in sign out is basically done at the end of the operations performed by the surgeon. And here you check is for ensure that your name of the procedure is recorded, because pre-operatively you could have said, I will do a laparoscopic procedure, but when you try doing it, there was some hesitancy and you were not able to do a laparoscopic, you went for an open surgery. So at the end of the procedure, this whole details have to be documented in your consent forms. Like you have to go and take a reconsent during intra-op that you are going ahead with the procedure, and the final notes have to come up into your post-operative notes. You have to have a correct instrument sponge count. So that's something that we'll see now in detail. So here, this is what you look into: your patient recovery management status, your post-op expectations, your medicines post-operative to be given, what are your lines and tubes present, your studies in case a repeat CT has to be done, or you need a repeat X-ray of the procedure, and where will the patient go? Will the patient go to the ICU, home, or the ward? So that's basically what we will see. Let's look at surgical counts. Now, there have been major errors, and various lawsuits which have been filed, because there was one gauze which was found later, probably an artery forceps or any kind of metal item found inside the cavity which was operated on. So you need to have an initial count that is taken when the instrument tray is assembled. You have your items which are separated, counted. You have a board wherein you place up and say these are the number of gauze, these are the mops, these are the other items available with me. You have a partial or an additional count. That is something which is added intraoperatively in case of your sponges or miscellaneous items, and it could be given by your circulating team or taken in the event of items being required in the absence of the counters. And the first closing count should start before the closure of a deep body cavity or a deep or a large incision. It has to have the field count, the table count, and the floor count. Okay, and the last is, sorry, the final count has to be taken during your subcuticular or skin closure, and a full and complete count of initial and additional items. So this is how your count breakup has to happen. Specimen labeling is another important thing. You have done a very good, surgeon has done a very good, excellent surgery. Everything went off well. And when you are labeling your specimens, either the specimens are incorrectly labeled, the specimens are not being dispatched to the lab properly on time, or there has been a mismatch and samples has been spoiled, then the whole purpose of the surgery is lost. Especially when you have patients for cancer surgeries, when you want to identify where the histopathological outcomes and accordingly start treatments. Kind of specimens which you send to the labs are very, very important. So important details to be mentioned is your patient's name. Everything has to be very, very legible. Key specimens have to be checked, verified by two people. Either it could be a nurse or a doctor, or it could be two nurses before they send the specimen to the labs. So you have to have your patient UHID number, IP number, your location, your collection date and time, your specimen type or source, your test required, and the ordering position. So sometimes we may have 7 or 10 specimens which are coming in, and please be very, very specific with the consultant or with the surgeon to identify the kind of specimen and the name of the specimen that has to be labeled clearly before you dispatch the specimens to the labs. All right, some important findings here. There was study which was done by this National Patient Safety Consortium in Canada, and they had found, they had done a 10-year review of the patients' files or the lawsuits which were filed in Canada. And during this period of between 2011 to 2015, I'm so sorry, yeah, 2011, 2015, they found out all the surgical safety care, surgical safety checklist related issues. And it was found that many a times these processes were inadequate, non-existent, or not even followed by the OR team. The analysis also showed that 2/3 of your surgical incidents, almost 35 out of 54 cases, occurred during the briefing or your timeout phases. So just even before the surgical come, there were many, many errors, and that lead to complications. So, and these events analyzed in the review took place with a variety of surgical specialties and involved all the members of the healthcare team. It was just not only nurses or your technicians or your surgeons, it was a mix of all. So what did they find out at each stage? Now, am I presenting this? Because these are the mistakes which have happened, and with the surgical safety checklist, if we institute it and follow it to the T and correctly, I think we can avoid all these similar kinds of incidences. So first, recurring themes which were analyzed were inadequate verification of the identity of the patient, failure to confirm whether the planned procedure and the site, lack of documentation of informed consent, absence of appropriate marking, and failure to display relevant imaging. Just imagine you're taking your patient for surgery and patient says, my X-ray is at home. Without your X-ray, you are not able to make a conscious decision. And then the surgeon kind of starts at the nurses. What did you check? OT nurses go and fire up the ward nurses, and the process is ending. So all this, if you see, there's a chain of events could be stopped if you are training your team to know exactly what is required, what has to be carried in, and this all items like your X-rays, your CT/MRIs, your films, everything are in place before the surgery starts. So these lapses were associated with wrong site surgery in 15 cases and performing the wrong procedure in 6 cases. So these were the analysis. Then further concern of the experts were absence of a timely review of the patient's documented clinical history or the results of pre-operative assessment. So pre-operative assessment हड़बड़ी में किया just for the sake of writing written okay OPD मैंने देख लिया patient को अभी जाने दो. Patient was viewed in the OPD, but today before I send my patient for the surgery, I have my labs which are coming to me, and I find my patient potassium is very high. I cannot just receive patient's lab and take him for surgery. Or today I find the patient suddenly to fall breathless and he requires O2. I need to have my anesthetist opinion again, do a full PAC again just to ensure that what is wrong with my patient before taking up the patient on for surgery. Or in case if you understand the surgery is required, then you fill up your high risk consent form, explain all those risks, all the details required for that risk assessment, explain it to the patient and relatives, then take the patient off for surgery. So here also, because the physician or anesthesiologist overlooking relevant risk factors, consultant recommendations, or abnormal laboratory investigations that would have required immediate follow-up. Second, less commonly where checking for patient's allergy status, your expiration dates, and failing to note the prophylactic antibiotics whether they were given or not. Again, what was checked in deeply clean cases was cases with issues involving sponge or instruments counts resulted in unintentional retained surgical items, erroneously reported as correct. That is, sometimes when if you would check back in your files, you would find that the sponge count and every count is correct, been signed by 2 or 3 people. But when the case was reviewed, this was erroneously reported as correct. So there was no tallying of your counts, no counter signature by the circulatory nurse and the scrub nurse, or maybe your OT in charge or a manager who's counting it and saying that everything went up well. So, see, in one case where the surgical count was correct, they found an 18 centimeter forceps which was overlooked and retained despite a final sweep of the cavity. Right. So this is something which was found. Again, number of cases, specimens which were procured intraoperatively were not processed appropriately due to the breakdowns in specimen management process, and hence there was inadequate communication of critical intraoperative events like respiratory arrest, and post-operative team members resulted in delay to initiate mitigating such therapies. So these were some of the things which were found. They have also done a review of the impact of this surgical safety checklist. What they found was over the past 1 decade, there has been huge lot of studies. There's an explosion of studies evaluating both the impact of the checklist and the challenges in its implementation. So they said this checklist was adopted by thousands of hospitals, numerous countries, and that was the standard of healthcare. Yet, the implementation of the checklist is not as simple as passing it along to the surgeon or nurse and asking them to fill up. They found that it was mainly an exercise of box ticking. That you have those small boxes, you tick mark, okay, ye ho gaya, ye bol diya, khatam ho gaya. Okay, without true fidelity, that nobody was doing a proper time out process in your operation theater. So they said that mandated use by, it was again, when we say NABH requires it, JCI requires it, I put a process and I put a checklist and it is there in my file. But is it really giving me meaningful improvements in my surgical outcomes? That's something to be known. Okay, and when implementation was done thoughtfully and with an understanding of the local context, the results and improvements resulted in even high performing hospitals. There was a greater increase in the surgical site safety outcomes. So maybe your SSIs were low, maybe the patient recovery was faster, your patient discharges happened, the length of stay was lesser. So you have more patients coming in. So you are, at the end of the day, the patient is happy, you are happy that the patient was taken care of well, everything went on well, and patient gets thankful towards your you can say your work front, that whatever you have put in place, your policies and your practices are equally followed right to the lowest level. So that's something is achievement at the end of the day. So an important mechanism of action of the checklist is to encourage behavioral change. Now this goes on saying for all types of checklists that you could put in place, it could be your handover checklist, it could be your vital signs checking checklist, whatever. It requires a behavioral change. You have to change the mindset of people to ensure that I am instituting this kind of a checklist so that I do not follow, I do not have these kind of errors which are in place. Or you start looking at in all your surgical site infections, your infection control team could start working in there and understand where did we go wrong. Was it because my antibiotic was delayed, or was it my antibiotic dose was never ever given, or whether my pre-op preparation was never ever done, or was it a haphazard process, or whether the patient was not explained to have bath. So when patient was explained to have a fluorexiting bath, patient just had a plain water bath and came ready for the theater. Was there anybody who was identified who would check whether all these my pre-operative things are in place? Maybe your ward nurse will say, "Oh, I had another emergency. I went for that. I didn't check, and I'm just shifting the patient to the OT just because my OT is, giving me multiple causes saying urgently patient to patient." So there are multiple factors involved. So you need to have a behavior change among all your levels of your nurses or your doctors to ensure that at the end of the day, the patient who is going on table has a safe pre-op procedures done, has a safe PAC done, and is fit for the surgical procedure right now. Okay, so that's basically your various improvements and safety culture that has to be placed in parallel. So you have to have a culture of safety. You need to work as a team, okay, without having a bias saying nurses can come in or technicians can come in, and this is only what is the surgeon requirement. If the surgeon has failed to, see certain point of view, you can always go up and say this is not being done. So that has to be coming right in at the time of signing. Or I don't have this radiological X-ray with me, or I don't have the CD with me right now for the procedure. So call to the procedure for that time. Or you have your consent which is not matching with the site. So consent may right eye cataract likha hai, whereas I'm marking the left. So hold on, stop the procedure and say we have to redo. Probably you may need to send the patient back to the ward. Okay, so these certain things have to be, empowered. Like when you empower your team members to take such kind of decisions or to voice out such kind of concerns, at the end of the day, your results, are excellent, or you provide a very safe environment to your patient. So support your team members, discuss any issues involving common and necessary surgical tasks. Follow your hospital policy and procedures. Like if you say, I need a patient's UHID number and the patient's full name to be called out during your procedure, ensure that your team follows it right from the wards to your surgery, to your OT theater or to your recovery room. And important is you use a structured communication tool. You could have, like for a handover, you have your SPA tool, or you could make a checklist for the pre-operative checklist for the nurse, like for the ward nurse and the your pre-operative nurse to follow to see that everything is being followed and is checked. And in case if there are any concerns, you need to document it. So for healthcare leaders, you need to define a clear surgical safety policy procedure. Ensure that you have appropriate resources for effective implementation. It's just not to download it, print, and give it off. You have to have the training of all these stakeholders who are going to follow that surgical safety checklist. And you have to have, that's a multidisciplinary education programs to support your policies. So future leaders need to support your checklist, ensure that your tools are in place, that you have your good teamwork, which is a central rule for surgery and provides an improvised sense of value to all theater personnel, right? So majorly what we have to concentrate is on in an improved communication for among all your members. And surgical safety, again, ensure that you have a safe and salubrious operating theater that's achieved through planning, maintenance, and at the same time, you should have periodic checks, whether your panel is working, your lights are working, your pottery is working, okay, as well as your ongoing training for staff members. Yeah, so some of the modern issues of patient safety, what we face or which has been clearly advocated by WHO is lack of continuous training and education. You have a huge turnout or attrition of nurses, you have a huge turnout of doctors or your technical team which is coming in place and has to have a continuous training and education. You need to have a past tolerance of unsafe practice. You say, oh, boss, we are not going, there has to be zero tolerance to it. We cannot have these same mistakes coming in time and again. You formulate your regulations rules which have to be followed by your team. In case if I have a surgery to be booked, it should not be just a verbal communication. You can have a printed format which comes is being documented and it comes to you in the OR. Okay, so you try to mitigate any gaps which are there in communications. you have any unstable, unreliable systems, work on it, get the team on board, understand what are their difficulties and put the things in place. Ensure that your staff is able to, come out and tell you what were the problems that they faced. That fear of admission of guilt and wrongdoing should go out. They should come and tell you, because so that you can rectify the process, and you have and ensure to have good policies in places so that the further same instance is not being reported, and kind of work on your human factors. So when your procedure, you are scheduling your procedure, ensure that it's in writing. That's what we said. Ensure your consent, history, surgeon orders are all in place. Pre-operative checkup is being done by the concerned team members. Any discrepancies should be mended, steps should be taken. Okay, mark your surgical site. Just before commencement of surgery, ensure that you are triple checking, double checking your patient's surgical information is worth the extra time. So you put in such a little bit of extra time, ensure that everything is in place before they go, and ensure that consequences of positioning related injuries are preventable. You can ensure that there are no cautery burns, no deformities, okay, because the patient was positioned in a particular way, no pressure ulcers or new neurological or vascular damage. Biopsy surgical, as what we have said, correct labeling, training of staff, knowledge of staff of why the specimen needs to be sent in that kind of format. If it has to go in formalin, if it has to go in normal saline, okay, clear-cut instructions to your medical team. Post-operative discharge workup, very, very important, has to be planned right from the time of admission to see what would be the post-operative workup. Education of patient is required. You either give them a pamphlet of what they have to do at home, somebody to demonstrate. You need to follow up for dressing every once a week or every third day. Clear-cut, discuss to them, identify the dates that they have to come up in your follow-up in your OPD. What is the diet measures, whether, what kind of measures they have to ensure to take for prevention of, infection of the surgical site. Clear documented handouts would be, quite a vital information. And patient education, in case, when you give a clear-cut education to your patient, it can reduce your complications, improve their quality of life after surgical procedure. So it can also reduce your complications. In case, could be if there are any language barriers, you have your format only in English, ensure it has been translated in their mother tongue. You have a patient who is visiting you who is, speaking in Tamil. So you have any of your colleagues at work in your hospital who knows Tamil, ensure that this has been drafted to them in Tamil and given to them for them to understand. Right? When you are planning your discharge instructions, you are planning your diet, keep in mind their socioeconomic status and ensure that you give them instructions which they can follow within their socioeconomic status profile. Okay, and important is, and consider their age and their impact, what they can have on their comprehension of instructions. Important is your education training of healthcare workers, of all your doctors, nurses, and other operating room staff. Helps to break down of hierarchy present in operating room, which is your communication channel, how your communication has to flow, who has to report to whom, but all this has to be clearly given. They should be comfortable in questioning the physician if they have something which they have found wrong. All right, so operational behavior becomes your pillar of strength for your safe surgery. So that's all that I had. Any questions which I need to take in can be taken right now. Thank you so much for your patient listening.
Thank you so much, ma'am. As always, it was great listening to you. I know everyone who is listening to this presentation of yours would have a ride from ward to OT and back to the ward with documents in their hands. And this detailed information on surgical safety with all the research data and practical examples, I know everyone will follow it in their own respective hospitals. Thank you so much for your time, ma'am. I now ask participants if they do have any questions, can drop out in question answer sections or the chat box. Thank you, ma'am.
Thank you, Priyanka.
Yes. Yeah. Moving further. Moving further. Now we do have our next again eminent speaker, Dr. Meera Achrekar, madam. Madam has completed her PhD, Masters in Nursing in 2001, professional diploma in clinical research and NABH SSS course in July 2009. Madam has over 25 years of experience in various hospitals, India and abroad, in nursing education and services. Madam is currently working as professor at Homi Bhabha National Institute and deputy nursing superintendent at Ektrek Hospital, Kharghar. I welcome ma'am for this webinar. Handing over it to ma'am. Thank you.
Hello, good afternoon, and thank you so much, Priyanka, for the introduction.
Yes, ma'am.
Good afternoon to all the participants. We are going to discuss a very interesting topic, which I'm sure you experience it so many times in your clinical setup. So I will share my screen. Is my screen visible?
Yes, it's
Priyanka?
visible, ma'am. Yes, it's
Okay.
visible, ma'am.
Okay, thank you. So we will be discussing today on prevention of fall and risk assessment. That is a topic that has been given to me. And I thank Dr. Prabha Dasila, Dr. Ms. Padmaja, and the MGM team for giving me this opportunity to present this session for you today. Like I said, when you work in the hospital, the first most important thing is patient first. I think this is our focus whenever we are caring for our patients. So when you look at, today we are having all sessions on patient safety. Patient safety is a discipline in the healthcare sector. And when we say about patient safety, we are talking about safety science methods. And why is it important? Because it minimizes the incidence and impact of and maximizes recovery from any adverse events. So today, in today's time with NABH and JCI coming in, I think there's a lot of focus which was required from a long time. It has come into the healthcare sector, and most of the hospitals are trying to implement that. So what I'm going to say may not be something new to you, but if it is, you are already an NABH accredited hospital or you already have JCI accreditation, this would be just a repetition. For those hospitals and nurses who are coming from those hospitals who are on the verge of going for any assessment, or you just want to improve your system, you may not have to do anything to do with accreditation, but you want to improve patient safety, then this is what we have to look at. This is the future for patients. So unsafe acts are like mosquitoes. When we say like mosquitoes, it is so irritating to have a mosquito bite you. And after it bites you also, you are so very upset about it. And what do? We try to squat one mosquito at a time. The mosquito which comes and bites me, I'll try to squat that mosquito. But when you squat them one at a time, there will be others which take their place. So why is this particular example given? The reason being given is for the mosquito to be diminished or to not have any mosquito in your setup, in your home, in your surrounding, the only remedy is to drain the swamps in which they breed. That means to say, if you have water collection, if you have drainages, if the surrounding is not neat and clean, if you don't take care of that core issue, the most important issue, then you will find that there are incidences that happen again and again. And for us as nurses, one of the most important thing is do no harm. So when we are looking at it from patient safety, we have to find remedies to ensure that our patients are safe. Incidents will happen. We'll have to try to spot them one at a time. But what our focus will be on what is the remedy so that this particular event does not happen. So the National Patient Safety Goals, this was already discussed, was established in 2002 to help organizations address specific areas of concern in regard to patient safety. And the first set of National Patient Safety Goals was effective from Jan 1, 2003. 3. And if you look at who comprises of these people, it is not the doctors only who have done it, or it is not some executives in healthcare who has done it. The panel comprised of patient safety experts, which included nurses, physicians, pharmacists, risk managers, clinical engineers, and other professionals who had hands-on experience in addressing patient safety issues in the healthcare setup. So when you look at the National Hospital Patient Safety Goals, all these sessions you will be covering up one by one. If you look at the 2021 patient safety goals, you will not find a particular one saying that risk for fall, but it has been incorporated into administering medicines cautiously. So this is one factor, but there are a lot of other factors also where you can have a fall. So even if it is not a part of the patient safety goals for 2021, in the patient safety goals of 2018, 2019, fall was one of the most important patient safety goals. And it still continues to remain even if it is not there in 2021, because there have been a lot of times we have been addressing this particular issues. So fall and injury prevention, it is a challenge across the care continuum. In the United States, whenever we look at healthcare, patient safety, any references, any journals, we look towards the West. But in this West, where there are policies and protocols which are in place for a long, long time, you still find unintentional falls are the most common cause of non-fatal injuries, especially for people who are older than 65 years, and so are fall-related accidental deaths. That means in United States, where everything has been set, there are patient safety goals, they are JCI accredited, there is magnet accreditation, so much of focus is given on patient safety. In those places, you will find there are patients who are having fall, and there are deaths also because of fall. And the studies have shown that females fall more frequently than males in this particular age group. That means in age group of the 65 years and above. So what happens if you fall? Say a patient fell. It's not the same. When the sequel from falls are very expensive, because when a patient falls, the length of stay of the hospital will increase. Patient may have additional injuries which will have to be taken care of. The cost implications will be very high. So fall-related injuries account up to 15% of rehospitalizations in the first month after discharge from the hospital. This is the US data, not the Indian data. We don't have actual data of the number of patients or percentage of patients falling in India. Each hospital may have their own, but we don't have a standard registry or somewhere where everybody registers their incidences. So based on data from 2000, total annual estimated cost for fall, patients who have had a fall and related to that was $16 billion to $19 billion. So can you imagine the amount of money which is being spent for something which can be, to most of the time, can be prevented? So let us look at one case scenario. Mrs. A is a 78-year-old farmer's wife that recently is admitted to your ward. She has Alzheimer's and is visited by her husband often. Her medical history shows hypertension, arthritis, Alzheimer's, and urinary frequency. Her medications are lisinopril, that is an ACE inhibitor for hypertension. She is also receiving hydrochlorothiazide, which is for hypertension, which also contains diuretic, and seroquel, that is psychotropic medication. Psychotropic medications. She has also had issues of stability and she falls very frequently. She is always well groomed and she keeps her home tidy. She wears glasses and not had any vision check in years. She enjoys cooking and listening to music. Now this is one scenario which has been given to you. Can you identify the risk factors over here? Is she a good candidate for fall?
Yes.
She is
Bolo.
Yeah, I'm sorry for the disturbances, ma'am.
April 1st.
Savya, ma'am.
April.
Yeah, I think Savya needs to mute.
Yes. I'll do it, ma'am. Just
Okay, thank you.
सर उस दिन पूछ रहे थे मेरे को मैं हम लोग आके आके मैं घर भाग गई ना 6 बजे सर कॉल की What happened?
Ma'am, just
So
give me a
sorry
minute.
for this
I'll do it,
disturbance.
ma'am.
I'm sorry for this disturbance. Okay. Can I continue? Okay. Hello. Okay. So if you look at this particular scenario, can you identify the number of reasons that this patient is a good candidate for fall? So let us see why she is a good candidate for fall. Now look at this. She has Alzheimer's. That means she cannot remember half the things that you have told her. If you have told her, don't come out of the bed, or you have told her that please ring the bell when you want me, she may not remember it. Okay. See her medical history. She has hypertension, so there can be electrolyte imbalances. She can have a fall. She has arthritis, that means she has ambulation issues. She is not able to walk, or she must be having pain because of that. She has urinary frequency, so she may have to run to the bathroom, or she may be afraid of passing urine in bed. She is on medications. For example, she is on lisinopril, which can have again problems with the dizziness. She's having diuretic, again frequency of maturation. She's on psychotropic medicines, which can cause a little confusion for her. She has issues of stability, and she already has history of falls, which is happening frequently. She has not had vision checks, so maybe her vision is a problem. So can you look at the number one patient, see the number of factors which may be responsible for her fall. So if you don't do a good assessment for her, if you don't assist and follow the fall prevention strategies, then she is a very, very good candidate for fall. So this way you may have many, many scenarios which are happening. I would like to discuss one or two. I'm sure if you are given an opportunity, many of you will have lot of experiences. I'll give you a few examples. For example, a patient had a head and neck surgery, and patient has a flap. So I don't know whether you have seen a patient with a head and neck surgery which has a flap. The patient, the body image is not very good to see. So this patient has a fall risk assessment done. At that point of time, the patient did not have any problem, goes to the washroom. In the washroom, there is a mirror. The moment the patient sees himself in the mirror, he gets a shock. He never expected that this is how he is going to look after surgery. And suddenly the patient has a vasovagal shock. Patient goes into a vasovagal shock. Patient falls in the bathroom. Luckily, no harm happened because the relative was standing with the patient. Most of the time you will find the fall happens when the patient is in the bathroom. There are different reasons, like environmental issues also would be there, which we will discuss later. But this particular patient, when he felt dizzy, he was getting out of the commode and feeling a bit dizzy, he suddenly held the tap. Unfortunately, the tap was, hot water was on because the patient wanted to have a bath also after he uses the washroom. When he felt dizzy, he held the tap and the tap just came off and the hot water was going in. The hot water fell on him. Patient had burns. So the patient didn't fall, but patient felt dizzy. Risk assessment done or not done? A big question mark. How did the patient go to a bathroom if he was at a risk for fall? But because of this particular issue, he had burns, some amount of burns, because of which his length of stay in the hospital was increased. Many of the times you will find patient going to the bathroom. The bathroom is, there is no tiles which are anti-skid tiles. The bathroom floor is wet. Patient steps into the bathroom, falls down. There is no grab handle for the patient to hold, or there is no call bell in the bathroom for the patient to call. The patient falls down. So this is another. Patient may have hypertension. We had another incident where the patient was supposed to get up to go to the washroom. She sat there and she suddenly felt dizzy. Instead of catching hold of the bed, she caught hold of the IV stand. IV stand is mobile. IV stand fell, patient fell, IV stand fell on the bed, patient got a injury. So these are some ways how patients can have, and I'm sure in every hospital of yours, you will have many, many more incidences like this because of which patient had a fall. So let us look at the definition of a fall. It is inconsistent with that of a medical error. So it is error of execution. That means a failure of a planned action to be completed as intended. That means if you have planned to perform a particular action of placing a call bell within the patient's reach, this is what you had thought of because you knew this patient was at risk for fall, but you have forgotten to keep the call bell within the reach. So what did the patient do? Patient wanted to go to the washroom. He is in desperate need. He wants to go, but because the call bell is not within reach, patient tries to get out of the washroom, of the bed and falls. So this is error of execution because you have not done something that you need to do. Second is error of planning. For example, the use of a wrong plan to achieve an aim. For example, if a patient has just come from physiotherapy, there is aggressive physiotherapy which has been done. Patient is still in that state, not comfortable, and then you are asking the patient for ambulation. So this is a wrong plan because as per our plan, when patient has had some physical therapy which puts the patient into imbalance, and then you have not planned your next activity, this can be a reason for fall. So this is first is error of execution, second is error of plan. The third is error of commission. That means an error that occurs as a result of an action taken. For example, the patient has had a ECT done for psychiatry treatment, and patient is, a patient who has received an ECT, that this patient is not in right mental balance, and you have not taken proper precautions to prevent a fall. So this is error of commission. So we have looked at error of execution, error of planning, error of commission, and next is error of omission, an error which occurs as a result of an action not taken. For example, if you have not done a fall risk injury for a patient is on psychotic medicines, or patient is on anti-epileptic medicine, or the patient is on diabetic medicine or hypertensive medicine. Patients are on all this and you have not done a fall risk assessment, then it is an error of omission. So error of omission is an error which occurs as a result of an action not taken. So let us look at the 4 things that we have to look at for a fall. Error of execution, fall happening because of error of execution, error of planning, error of commission, and error of omission. Formerly, JACO in its national patient safety goals advocate for institution-wide risk assessment for falls. That means every patient who comes to your hospital, you must do a risk assessment and document of a fall prevention program. So all hospitals, irrespective of whether you're going for accreditation or not, if you want to improve patient safety, you must have a policy on fall prevention, policy on fall management. So fall prevention means what will you do to prevent a fall from happening? Fall management means once a patient falls, how will you manage that particular patient? And you must have a risk assessment for falls. That means every patient who comes in, you must do a risk assessment whether this patient is at a risk for fall. These efforts have the potential to eliminate latent errors related to falls and injuries. So how do you reduce the risk of patient harm resulting from fall? Fall is one of the factors which can cause a harm to the patient. Wrong medications can cause harm to the patient. If you have a pressure ulcer, it can cause a harm to a patient. But here those sessions are already dealt with other eminent speakers. We are going to deal with only falls. So fall mostly occurs in the age group of 40 to 65 years. It also occurs in children, and most probable place where the fall can occur is the bathroom. Fall may not harm always, but it can cause pain. For example, if I fell and I got hit on my head, I may not become unconscious, but my head will pain because I have had an injury. Or if my hand has been twisted or my legs have been twisted because I have fallen, that means I am going to have pain now because I have had a fall, which was not there earlier as a part of my disease condition. There can be decreased mobility because now I have had a fall, my head is paining, or my knee is paining, or my ankle is paining, or my hip is paining. I will not be able to walk. And once a patient falls, there is always a fear that the patient will fall again. So what are some of the fall prevention strategies? Like I mentioned earlier, fall risk assessment on admission. Every patient who comes to your hospital, say many hospitals have initial assessment for the patient. The hospital can define within how many hours you need to do your fall risk assessment. It is better to finish the initial assessment in the first 15 to 30 minutes. You can do a detailed assessment later on, but one of the assessment but which must be included is your fall risk assessment. So on admission, you need to do it, and whenever there is a change in condition. For example, patient on admission had a fall risk of low. Patient is not at a risk of fall, but now the patient has got hyponatremia or a hypokalemia or hyperkalemia, hypernatremia. Patient can have a risk for fall. Or patient has gone for a surgery. Now the condition of the patient has changed. Patient has a risk for fall. So you need to do a fall risk assessment on admission and whenever there is a change in condition. And if you find that the patient is at a moderate risk or a high risk, then every shift you must do a fall risk assessment. I will share with you the fall risk assessment format in the next few slides. You should have a fall precautions sign. It can be over the bed. If it is a room, you can have outside the room. Some hospitals put a band saying that the patient has a risk for fall. So you can have color-coded bands which are there, or some hospitals may have maple leaves which are there, which they attach to the head end of the bed or outside the room. A maple leaf is an acceptable sign of fall. So when you want to say a patient is at a risk for fall, you can put a sign of a maple leaf, which the healthcare person will know that this particular patient who's on this bed or on this room is at a risk for fall. So identification by color band, I already told you, it is nice to have a color band because the maple leaf will be only on the bed or outside the room. But if you put a fall risk band on the hand, then when the patient goes to another department, for example, goes for diagnostic procedures or go to some other department, the fall risk band will show that this patient is at a risk for fall. So make it easy to identify high risk fall patients. Then do safety rounds. This is very important. As managers, as nurses at bedside, I would say each of you is a leader. You can look around and say that, okay, this particular wire is coming in. I think this is a risk for fall. Or my bathroom is having slippery walls or soap is there every time. How do I keep it dry? A safety round will tell you. If you find that the surrounding is not safe, the steps are not safe. Sometimes when a patient has to walk down the steps, you will find some steps are broken. That also is a risk for fall. So when a safety round is done by hospital management or the nurse in charge or by the bedside nurses, you will be able to identify any risk factors which can lead to fall in a patient. Sometimes near the bed end of near the bedside, you have the IV infusions, you have the bed attached to the electrical panel, and all those wires are lying around. That also can be a risk for fall. Okay, so this safety round will help eliminate any issues that you are having with not only falls, any other issues also. Then the call bell should be kept within reach. This is very important. And you need to tell the patient, just keeping a call bell on the side will not help. You need to tell the patient, this is a call bell. Where do I keep it? Is this hand comfortable? Is the left hand comfortable? Keep it within reach. And you need to tell the patient, whenever you want to get out of the bed or you want something, please ring the bell. I will come as early as possible. If a relative is there with the patient, tell the relative also that you please ring this bell. I will come and assist you. So bell within reach is a very, very important factor. Then keep necessary items within reach. For example, if I want, nowadays everybody wants to see their mobile all the time. Some people may want specs or hearing aids, or they may want their the cane to walk around. So whatever is required for them, keep it within easy reach so that the patient doesn't get up from the bed and try to reach it and have a fall. Keep the bed as lower as possible so that even if the patient falls from the bed, the risk of injury will be lesser. Keep the side rails up whenever the patient is not required to be moving around, especially if a patient is at a risk for fall. Check for brakes, whether the brakes are on the bed, on the stretcher, on the wheelchair, wherever patient transportation is going to take place. Please check whether the brakes are in place. So this will ensure that the wheelchair or stretcher or bed doesn't move and the patient doesn't fall. When a patient is wearing close-fitted shoes, it is seen that the chance of tripping over and falling becomes very, very less. So if they can wear a closed, well-fitted shoes, it will be advisable. If not, then they can wear the other slippers, but then they have to be careful, and you as a nurse has to ensure that no wires and drugs and other things are lying around. Advise patient to sit at the edge of the bed before standing up. Most of the people have orthostatic hypotension. So whenever you have a patient, especially all patients, especially if you think that the patient is at a risk for fall, you will ask them, when you get up from the bed, sit at the bed for some time and then only get up from the bed. If the patient has elimination issues, urgencies of elimination, and the washroom is little far away, please ensure that the bedside commode is there within reach so that the patient doesn't struggle to go to the washroom and have a fall. Whenever there is a transition of care, you are shifting the patient from here to another ward, or you are shifting the patient to another department, you have to inform the other department that this patient is at a risk for fall. This also need to be done when you are handing over from one shift to the other. You need to tell the next nurse on duty that this patient is at a risk for fall. And it is also advisable to avoid wearing loose fitting clothing, because if you have loose pajamas or loose gowns, the patient can trip over. So you need to ensure that the patient's clothing are comfortable. The environment. So if you find there is any spills or any liquid which is lying around, you need to ensure that that is taken care of. The housekeeping has to ensure that this is done. If you are mopping some area, they need to put a wet caution board so that people know that when they are going to move ahead, it is going to be wet. I already mentioned, keep unit clutter free. That means your equipments, your tubing, your footstools, your IV stands, everything has to be kept in its order so that the patient doesn't fall. Provide assistive devices like crutches or walker or wheelchair if the patient requires for ambulation. Your washrooms, ensure that there is grab bars in the toilet. This is very important because sometimes when a patient is getting up, if it's an Indian toilet, all the more, because the distance they have to cover to stand up will be very high. But even in a cupboard, it is better to have a grab handle so that they hold the grab handle when they stand up, so that even if they feel dizzy, they have some support. It is also good to have in good hospitals and the newly coming hospitals and hospitals who are trying to improve their patient safety standards will also ensure that there is a call bell inside the washroom of the patient. So in case during any event, if the patient feels that there is a need, then you will, the patient can give a call. Also, it is advisable that the toilet door inside the patient should not be able to lock, because in case the patient locks down and the patient falls inside, you will have to break open the door to go inside. So advising the patient not to lock the door, or better not to have a locking system so that the patient doesn't lock the door, is also another way not to prevent a fall, but in case a fall happens, how do you reach the patient? So this is another important aspect. And you will also find many of the hospitals have the washroom door opening outside. Because if your bathroom is small and if patient has fallen down, and when you open the door inside, you will have no space, and the patient will also not have a space, and you will not be able to move the patient. Disabled friendly washrooms are also good in many of the hospitals. New construction especially, they are doing it. So patient can go right with the wheelchair into the washroom of the hospital or their room. You will find in most of the airports, you have this sort of a system. So the wheelchair can go in, so the distance that the patient have to walk will be reduced considerably. And in those washrooms, you will have specially long, elongated the side rails or grab handles so that the patient has a good hold before they sit into the toilets. Then if you have a slippery tile and you can't change it, anti-skid mats or tiles can be used. Tiles are better because you will be placing it all around. If it is not possible, then anti-skid mats are also good. Inside the room of the patient, it is advisable to have night light or lamp. The light has to be right, because if you switch on the room light, the patient will find it difficult to sleep. A night lamp will give adequate ventilation and the call bell within reach, so that the patient will be able to call whenever he wants to, and will find the call bell also when they want it. So the lighting also has to be right. Then when transferring patient from bed to wheelchair or stretcher, or from wheelchair, stretcher to bed, you must ensure that the brakes are locked. This is very important. Otherwise, when you're moving the patient may fall. Move footrest aside. When you are removing the patient from the wheelchair, the footrest, the footboard which is there, that has to be folded so that the patient can stand comfortably. Otherwise, the footrest will hinder the patient's movements. There are some hospitals which use a gait belt. That means it's a belt which is worn to a patient, and you hold the patient's belt to move him from the wheelchair to the bed, or from the bed to the wheelchair. There is also pivot disc which is available. You have to be a bit careful because the pivot disc moves. So you keep it below the feet of the patient and you ask the patient to stand on it. Because it is pivot, it is circular in movement, it moves, and you will be able to shift the patient safely from the bed to the stretcher wheelchair, or from the wheelchair to the bed. Another very important thing is your handover tool. It can be S-bar or any handover tool, or you just your documentation that you do. You need to inform that this patient is at risk for fall. You need to also tell the relative that this patient is at a risk for fall. So the most important thing is call, don't fall. Call, don't fall. So if they call you, you will be there to assist them. You can prevent a fall from happening. So there are many assessment scales which are there. Morse scale is the one which most commonly used by many hospitals, and it is easy to implement. You can look at the Morse scale or any scale that you want, and you can decide what are the parameters that we want to use. In our hospital, we use a modified Morse scale, but you can decide to use a scale as it is, or you can modify it. So according to Morse, inpatient falls can be classified into 3 categories. One is accidental falls, like that means, for example, extrinsic factors like environmental consideration. We saw how environment can be a reason for fall. Second is anticipated physiological falls. That is, patient may be confused, or patient has some problem because of electrolyte imbalance. So those are physiological falls. And third is unanticipated physiological fall. For example, patient may have a syncopal event, or can have a stroke, or like I told you in an earlier example, a vasovagal shock. You are not expecting it, but it may suddenly happen. So these are 3 categories according to Morse where an inpatient fall can occur. So this is the fall risk assessment that we use in our hospital. This is a modified fall risk assessment. You can use the same one, you can modify it, there are a lot of options available. The primary goal is to do a risk assessment, so you are able to identify a patient who is at a risk for fall and take measures accordingly. So in this, we have mental status, age, mobility, fall history, patient care equipment. For example, is a patient on an IV pump? Does the patient have an indwelling catheter? Do the patient have drains? Then the medications. Is the patient on anticonvulsant, antihypertensive, diuretic, narcotics, sedatives, psychotropics, laxatives, hypoglycemic drugs? All those drugs, medications are very, very important. Next, elimination issue. Is there a frequency in elimination? Is there an urgency in elimination? Or is there an incontinence in elimination? If there is frequency in elimination, also patient will be wanting to use the washroom very frequently. Urgency, diarrhea, mujhe abhi jana hai, or the patient is not able to hold the urine or stool for some time, that is urgency. And incontinences, patient does not know that there is a issue. So these are different factors under which we do our assessment. And according to that, we grade the patient as low risk, moderate risk, or high risk. So if the patient is at a low risk, if there is more than 3 low risk, you will assess the patient for fall once every shift and we will implement the universal fall prevention protocol. If the patient is at a moderate risk, so moderate risk means 1 moderate and 3 or more low risk or 5 low risk. So if 3 low risk means low risk. If there are 5 low risk or there is 1 moderate risk, then 1 moderate with 3 low risk, then we will consider that patient as moderate risk. And if there is 1 or more high risk or there is 2 or more moderate risk, then this patient will go into high risk. So for moderate risk and high risk, we will assess patients once every shift, implement high risk and moderate risk fall prevention protocol, and we will document all this in our nurses progress sheet. So this is the assessment we do. After all the assessment we do, still the patient can have a fall. And if you have a fall, you need to do a RCA, that is a root cause analysis, and you also need to do a risk matrix. So this is a root cause analysis. There are different ways of doing root cause analysis. This is the most commonly used. This is called as a fishbone diagram, or it is also called as cause effect diagram. So this is for patient fall. So in your organization, if you find there is an increase of patient fall, then what you will do, you will have to look at, was the problem in people, was the problem in material, or was the problem in process? In people, is it staff deficiency? They have not met the standards for routine care, or is there a shortage of staff? In materials, is there no signage for falls? ID band for fall is not there, or the call bell is not functioning, or there is no assessment tool, or lighting was not adequate. In process, there was inadequate fall risk assessment process, the improper cleaning of the housekeepers, there is no policy on fall risk. This is an idea which gives you where exactly the problem happened, because of which there is an increased patient fall. So this is a fishbone diagram. This people material process, this is just an example. There are a lot of other examples also. For example, in this you will see the communication factors, workload factors, education factors, personal factors, patient factors, team factors. So you can think of so many factors which you can add into this fishbone diagram because the patient had a fall. So hospitals, when there is a fall, for each individual patient, they do a root cause analysis. If there has been an event of falls also, they will try to do a root cause analysis. So this root cause analysis will help you understand where the problem is. So it is not a blame game. Suppose I as a nurse has forgotten to switch the bed light on, night light on, or I have not given the call bell within reach because the call bell is at the head panel and it doesn't have a wire down. What is it as an administrator that I need to look at? I will not blame the staff, or I will not give punitive action to the staff. I will look what process went wrong. Was there work overload? Was there is a staff shortage? Was there a problem with the process which is involved? So this is a sort of diagram which will help you to identify what is the problem and then take preventive measures or corrective measures. So this is another postpartum fall. So here you can see the thing is changing. Here you have only people, material, process. Here you have communication, workload, education, personal, lot of other things which are added. Here you have added many more. So it is your creative thing. You can add whatever you think it is important to identify what caused a particular fall in a patient. So this is called as a fishbone diagram, cause effect diagram. So this is something that you can use to identify. Not necessarily the management does it or your quality manager has to do it. You as in charges, you can do it. You as a bedside nurse, you also can do it. Or you can get involved as a team to identify what is the cause for having a particular fall in your organization. So the National Database of Nursing Quality Indicators define fall. We already saw fall, definition of omission, commission, and all those things, but also defines fall as an unplanned descent to the floor. Means for whatever reason, maybe because of trash or equipment or environment or whatever it is, fall is an unplanned descent to the floor. That means you're not expecting it. It has suddenly happened. And with this, you can have injury or no injury. So all types of falls are included whether it is for physiological reasons or environmental reasons, all falls will be included when you're doing your quality indicators. So when you look at NABH quality indicators also, fall is one of the quality indicators. So if you have too many falls, it shows that a lot of attention from the nursing side is required. So this is how we benchmark and we decide how good is the nursing quality indicator. This is a risk matrix. So you can see this is the likelihood and this is the consequences. In consequences, you have insignificant, minor, moderate, major, severe. And in likelihood, you have almost certain, likely, possible, unlikely, rare. For example, if a patient has had a fall risk assessment done and you have taken all measures, still the patient had a fall, then it may be a rare event that such a particular event can happen. Otherwise, if a fall risk assessment is not done, then there is a chance that most certainly this incident is going to happen in another patient. So one is likelihood, how frequently can it happen? And second is consequence. One fall has happened, whether this particular fall which is there, is it as low risk, it is at medium risk, high risk, or extreme risk. So this is how you will chart a matrix and you will decide a score. So none means that indicates that the patient did not sustain an injury secondary to the fall. Minor means there were minor injuries, required simple intervention like thoda abrasion ho gaya and you just had to put some bandage and it is fine. Moderate indicates that there was injury because of which there had to be sutures or you had to apply splint. 4 is major injuries. That means it required surgery, it required casting, further examination. That is major injuries. And extreme or severe or this is death that results from injuries because of the injuries which has been sustained from the fall. So this is called a risk matrix. So here we finished with all the other things related to fall, but there is another important thing we need to remember if we are looking at patient safety is empathy. Empathy is a capacity to understand what another person is experienced from within the other patient's frame of reference. That is the capacity to place oneself in another's shoes. So when you look at a patient who is anxious, the patient whom you think is not looking okay. So this observation, understanding what is very important in a patient, empathetic feeling is also important for you to prevent a fall. For example, if you feel a patient is anxious, looking confused, you should not do any intervention at that point of time which will lead for fall. You want to ambulate the patient, this is not the right time to fall. You want to shift the patient to another department, patient is looking too anxious, jittery, not a right time. You should call the department and tell them, okay, we will send this patient after 15 minutes, half an hour. Patient doesn't seem to be in a state of mind to transfer. So a nurse must be sincere and really care about what happens to others. Again, patients first is the core thing that you have to look at. So clinical empathy involves an ability to understand patient situation, perceptions and feelings. What is the patient going through? To communicate and understand, check for accuracy and try to be helpful to the patient. There has been study on effect of nurses' empathy on anxiety, depression, hostility, and satisfaction of patients with cancer especially, showed significant reduction in anxiety, depression, hostility in patients being cared by nurses exhibiting high level of empathy. So empathy is so very important. The patient should feel, okay, this is the nurse, I'm not feeling okay, I should be able to tell her that I'm having a problem. If you are a nurse who is not empathetic, you are not connecting to the patient, patient may fear telling you if they have a problem. So empathy is very, very important in quality of care. So in conclusion, I would like to say policy, every hospital must have a policy on fall prevention, fall management. In fall prevention and management, you should have for low risk, what will you do? For moderate risk, what can you do? And for high risk, what you need to do. Hospitals can devise their own methods on how they are going to prevent a fall. A lot of guidelines are available that can be used. You need to do a fall risk assessment because the fall risk assessment will tell you whether this particular patient is at a risk for fall. Patient identification, if you can put a band or you can put some identifier saying that this patient is at a risk for fall. At one glance, when you look at a patient, you know that you need to be careful because this patient is at a risk for fall. One of the most important ways on how you could prevent fall is keeping a call bell within reach. If you assure the patient and don't keep only the call bell, when a patient rings the bell, please see that somebody attends the patient. Otherwise, patient will call and call. There is an urgency for the patient to go to the washroom, will jump over the side rails if there is an urgency. Some beds have side rails which have the rails are not fully covered. They may try to walk in from the gap which is available. This can be a risk for fall. So whenever there is a risk, whenever there is a fall, you need to do a root cause analysis and also do the risk matrix so that you know that such event is going to happen and what is the status of the patient. Was it none, minor, major, death, whatever it is. Need to hand over these patients from one shift to the other, from one department to the other, saying that the patient is at a risk for fall, so that all the members of the healthcare team are aware that this patient is at a risk for fall. Most important, when the patient is going home, this is very important. Our all focus is on the patient who is in the hospital. But medications are the most important thing. I'm sure it was covered up in medication aspect of patient safety. Patients who are receiving any of the drugs that we mentioned, like for example, anti-epileptics, psychotics, sedatives, laxatives, or patient who is getting diuretics, the patients need to be told what preventive measures has to be done in their homes. And their home environment also, how do they need to keep it clutter-free so that there is no chance of fall. So these strategies for home care should be a part of your discharge planning. So behind every great doctor is an even greater nurse. So in India, we nurses have to be self-confident, proud of our profession, not tolerant to unfair subjugation, and we have to be assertive. The doctor doesn't have to tell you that you need to do a fall risk assessment. The doctor should not be telling you that, oh sister, this patient is on hypertensive, anti-epileptic, oh patient is old, dekho fall ho sakta hai. That should not be the scenario. It is the nurse who has to be assertive and say that this patient is at a risk for falls and these are the measures and I'm not going to deviate from the measures. Okay, so thanks so much. Any questions I would be willing to take?
Thank you so much, madam. I know each one of the participant had this visual ride. I hope I'm audible. Had this visual ride of their own patients, and they'll do this fall risk assessment of each and every patient admitted in their hospital. I request all the participants, if they do have any questions for the ma'am, they can drop in the question answer section or in the chat box. We'll forward it to ma'am.
Thank you so much.
Yeah. Thank you so much, ma'am. Before moving further, I would like to request all the participants to be attentive for the post test and the feedback section, which we'll share soon. Now we'll move on to our next speaker. Now, I invite Mrs. Maria Preeti Matthew, madam. Madam has a total 16 years of experience in various nursing fields, including bedside nursing, supervision, and teaching. Madam has completed her BSc and MSc Nursing from Father Muller College of Nursing, Rajiv Gandhi University Health Sciences, Karnataka. Madam is a lifetime member of several professional organizations. She has presented papers at national and international level, organized various conferences and workshops. Madam currently working as an associate professor in MGM New Bombay College of Nursing, Kamote, Navi Mumbai. I welcome ma'am for this webinar. Handing over to Preeti ma'am. Thank you.
Thank you, Priyanka. Can you hear me?
Ma'am.
Yeah. Good afternoon, everybody. Morning onwards, so many classes you have attended, or so many topics you have attended. So I know you people are bored of listening for R&R. So we were we are here now at the end of the session. That is the last session. And we have seen that from morning onwards, we were seeing mainly the international safety goals. And we have seen almost 4 goals. And now I'm here to discuss you regarding the 5th goal. That is, mainly it is given as a reduce the risk of healthcare associated infection or prevention of healthcare associated infection. So reduce the risk of healthcare associated infection. Why infection control is so relevant in the patient safety? Why it has come one of the important element, and it is given as an international safety goal in the patient safety. If you see the mainly the WHO, CDC, as well as the overall statistics, or if you read their fact reports, I'll be going to show you that the spread of infection in the healthcare setting today affects the hundreds, from the hundreds that gone to the millions of people worldwide. And among the healthcare settings, the infection is one of the, it is counted as one of the adverse event. So that's why it is very important for us as a healthcare providers or nurses to prevent the healthcare associated infection. Everybody knows she's a pioneer and she's the first infection control nurse. According to her code, she has told the very first requirement in a hospital is that it should not do sick, no harm. That means the patients those who are coming to our hospital, they are coming for the, if I'll tell, for the treatment, for the betterment, as well as to improve their health. After coming to the healthcare services, we, the healthcare providers, should not give any infection to that particular patients who are coming to us hoping that they'll be recovered, they'll be getting a good care. That's why the Florence Nightingale itself, she has told that it is very important that we should not do any harm to the sick people. When you come to the hospital, we know hospital is a breed for many infections. The infections which are visible, the infections which are not visible. The people those are coming in contact with or coming to the hospital, it's not only the patient, it is also the visitors, the nurses, the paramedicals, the doctors, the health workers, the dietetic people, the laundry people, everybody. So how good we are to detect and makes the difference to prevent the health associated infection. If you see the healthcare associated infection, earlier known as the nosocomial infection, it is derived from the Greek word that is called as nosis, which is means disease, and the chemon, which means to take care of. So the healthcare associated infection, or what we call it as a HRAs, are the infection that occur while receiving the health care. That means that the infection which occurs when the patient are in the healthcare system. It is very significant cause of nowadays of increase the morbidity as well as the mortality in the hospitalized patient. The patient may come for some disease condition or a surgery and land up with some great complication or a deformity, or sometimes even for the death. The patients might have come for some infection or some conditions, or the patient is put under ventilator, or after some times the patient developed the infection, started showing the reaction in the body, the fever increases, no antibiotics are able to bring down the infection from the patient. The patient will go into a state of ventilated associated pneumonia, and without no reason or without doing anything, the patient may land up into fatality. So this is one that it may cause a mortality, but it may also cause prolonged hospital stay. The patient may come for only for 3 days for some surgeries, and the surgery is not as surgery is developed to some other complication, maybe surgical site infection, oozing it started. So the stay in the hospital may prolong. Are inconvenient for the patients also, even for their relatives also, because of the lengthy stay, and they constitute huge economic burden on the healthcare system, not only on the healthcare system, also to the patient as well as to the family member. The patients with the medical devices. So when when the patient comes to the hospital, the patients are with various medical devices. That is, there are many central lines, there may be a urinary catheters or various catheters, they may be on ventilators, or sometimes the patient may undergo surgical procedures. These are all come under the risk of acquiring healthcare associated infection. So according to the CDC fact sheet, it is estimated that in a given day, 1 in 31 hospital patients has got healthcare associated infection. And also, as per the National and State Healthcare Associated Infection Progress Report, it has been told that there may be certain reduction in certain healthcare associated infection like CLEP-C, COT, surgical site infection, that is from 2018 to 2019, but there is no significant change in the surgical site infection following the abdominal hysterectomies or hospital onset of MRSA, and there is increase of about 2% in the VAP, that is ventilated associated pneumonia, between 2018 to 2019. So this fact sheet gives some relevant information which caused due to the healthcare associated infection. There may be certain progress has taken place in some of the HIAs, and there is some deterioration or it has gone worst. The WHO fact sheet gives, if you see the WHO fact sheets, of every 100 hospitalized patients at the given point of time, the 7 in the developed countries as well as the 10 in the developing countries will acquire at least one healthcare associated infection. There may be at least one healthcare associated infection. That may be because of the catheters, or it may be because of the patient is on ventilator, or it may be because of the poor hand hygiene that is done by the healthcare workers. Because of that, the patient may develop in developed countries about 7, as well as in developing countries about 10. At any given time, the prevalence of the healthcare associated infection may vary from 5.7% to 19.1% in the low as well as the middle income countries. As we all know, healthcare associated infections we cannot eradicate it, because some or other time there may be some deviation or a variation or something may occur. It is a fault of a healthcare workers, or maybe because of the immunity of the patients, or maybe the healthcare structure it's like that. So we cannot eradicate it, but a well-conducted prospective surveillance. Why it is surveillance? It is a series of movements. Why it has happened? What is the cause for this? How long it particular condition has come? So the surveillance is a golden standard for many significantly reduce the healthcare associated infection. Now, however, this approach requires a comprehensive resources as well as coordination prevention program. So if you see the definition of healthcare associated infection, which is given by WHO in the WHO bulletin, it is known as, it is a nosocomial or a hospital infection, as we are already told. It is an infection that is occurring in a patient during the process of care in the hospital or other healthcare facility, which was not present or incubating at the time of admission. So at the time of admission, this particular condition or infection may not be there, or the patient may be in the incubation period, or during after the hospital stay, this particular condition has come up. So HIA includes the infections which are not present or incubating at the time of admission. For example, there may be UTI, urinary tract infection. There may be chance for the high grade of fever. There may be chance for septicemia, which may not be there at the time of admission. But once the admission has occurred, because of the various condition or various factors, the patient may develop the infection. To appear the infection that it may appear more than 48 hours after the admission, those acquired in the hospital but appear after the discharge. That means the patient might have acquired in the hospital, for example, the malaria. Mosquito bite might have occurred in the hospital, but the signs and symptoms patient might have shown after certain days. Or any infection related to your IV cannulation. The patient might have started the redness after going home. Or occupational infections. So I'm not going to detail in regarding the occupational infection. And occupational infection also as a part of a hospital associated infection, which result from the needle stick injury or exposure to the blood as well as the body fluids. What are the risk factors for this healthcare associated infection? There are various risk factors. The admission itself to the emergency or ICU is a risk factor, because the patient going to the ICU means the patient is with so many tubing, so many catheters, and so many procedures, and the patient is going on, and that itself will be a risk factor for getting the healthcare associated infection. Hospital stay longer than 7 days. So if it is more than 7 days, as you know, hospital environment itself is full of microorganisms. It may be a bacterial organism, it may be a fungus, it may be a viral organism. So the environment itself, the bed which he sleeps, the side lockers which he uses, the toilet, the handles, the wheelchair, the stretcher, everything. So this all environment itself has got a lot of microorganisms. So if the patient's immunity is less, if the patient is malnourished, if the patient is not eating properly during his hospital stay, there may be chance for getting the healthcare associated infection. Also, the placement of central venous catheter, the placement of indwelling urinary catheter, the placement of endotracheal tube, the placement, or if the patient is undergoing any surgeries. These are also at the risk of getting healthcare associated infections. The patients with immunosuppressants, the patients who are cancerous patients come for the chemotherapy, the patients who are undergoing radiotherapy, the patients with using corticosteroid, these are all at the risk of getting healthcare associated infection. The patients with neutropenia or rapidly and ultimately fatal diseases that may impair the functional capacity of the patient, or the patient who is in coma. All these patients are at a high risk of getting healthcare associated infections. The other conditions are, if you see, we can call it as a, that is the, sorry. So inadequate hygiene of the environment, or not properly waste disposal, proper waste disposal. If you are not doing properly, biohazard waste, if you are keeping like that, or it is not kept in the proper container or a plastic bag which is provided for the biomedical waste to put, or if the environmental hygiene is not at all proper. The poor infrastructure, because as you know, infection can come, or it is there everywhere in the environment. If there is no proper cross ventilation, the rooms which is provided to the patients are very stuffy rooms, the patient, or it is very closed rooms where there is no ventilation, or the patients are kept very nearby, the close to each other. So there is a poor infrastructure. There is no proper toilet facility or the bathroom facility for the patient. Insufficient equipment, because we know whatever procedure we are doing, there is something called as a clean tray as well as the sterile tray. So if you don't get adequate sufficient equipment for doing the procedure, for dressing, we require this proper what you call it as a sterile thing. Or if you are going to do a urinary catheterization, central line insertion or intubation, we require a very sterile tray with the sterile equipment. Here, it is not sufficient in that particular hospital or in that particular health sector. That may be one of the provoking cause for the health care associated infection. Understaffing, as everybody knows, and we are ourselves experienced what is the consequences of this understaffing. The staff is overburdened, so staff has forgotten to do her own hand washing, forgotten to wear the sterile glove, or forgotten to change the glove from one procedure to another procedure. So then overcrowding of the patient, overcrowding of the environment where the patient is kept, the poor knowledge and application of the basic infection control measures. The healthcare workers, those who are working in the ICUs or in the ward or in the healthcare sectors, should have a good knowledge regarding the what is the problem, the knowledge regarding the what is the vector that causes that particular problem, what is the mode of transmission of that particular disease, any disease or any infection, what is the type of infection that is. So all this knowledge, the basic principle of control of infection, mainly the basic hand washing procedure, that is very compulsory, which is there in any healthcare sectors as a policy. The using the sterile procedure to do the sterile mainly while doing the invasive techniques. So application of this basic infection control measures is very important. Otherwise, it may cause healthcare associated infection. Lack of sophisticated procedure, lack of knowledge of injection as well as the blood transfusion safety. Anything the blood is brought, kept on the tray or in the locker of the patient, and the same cannula IV, which is already the fluid is going on, it might have bulged or it might have blocked. In that only they started giving proper preparation of the site for the injection properly. After giving the injection properly, how we are closing that knob, or sometimes it will kept open itself, which is itself will cause a transportation area for the microorganism to enter into it. Absence of the local and national guidelines at the policies. This we cannot tell nowadays, because WHO as well as that is CDC, Center for the Disease Control, that particular center itself has given the various guidelines for each of the diseases, and as well as infection control policies. The various guidelines are given. So adopting this guidelines, which is already given by the recognized organization, it is very important to prevent the healthcare associated infection. So these are the various risk factors on which there may be a chance for the patient as well as the healthcare providers may get the healthcare associated infections. So these are some of the sources of infection in the hospital. I've already told there may be, the patient may be sleeping or along with the another patient who is having some contagious disease, or it may be a patient with the tuberculosis, or the patient with MDR patient, or and the other patient who is sleeping along with that patient, or the next patient may be a immunosuppressant patient or malnourished patient. So this is what the other patient may be the source of infection. The visitors who comes to visit the institution or the hospital or the patient, they may be the carriers for many infections along with them. They may be the carriers, or they may contain the microorganisms in their hands, and when they'll come and touch the patient, the surface of the patient, they may be transmitting this microorganism. And when the patient touches that, he, because of his condition, because of his immunity, he may get the infection. The hospital person itself, the healthcare persons, we nurses, the doctors, the housekeeping people, the paramedical people, the instruments what we are using in the hospital, that is our aprons, our stethoscope, the BP apparatus or digital BP apparatus. There is a equipments what we are using in order to treat the patient may contain various infectious agents. Surgical procedures what we are doing also may be the source of infection if you are not done in a sterile manner. The air what we breathe, as we know, we are there in the COVID pandemic. So all of us, we know that it is considered as a airborne disease. That's why we are all wearing a mask. So like that's only the airborne disease, the tuberculosis, it is also airborne disease. So they may be, the microorganisms may be there in the air, water and the food. The diarrheal diseases may come from the water and the food. The typhoid may come from water and the food. The patient normal flora itself sometimes cause as a source of infection. The fomites contamination, the articles what we are using, or mainly the articles which is used for the patients may be a source of infection, and devices, the drains as well as the catheters. The most common types of, or the site of nosocomial infection, if you see as CDC has given, it is maybe the urinary tract infection, it is a surgical site infection. Like urinary tract infection, you can see about 40% of the cases, you can see. Next, surgical site infection, then lower respiratory tract infection. Sometimes it is the bacteremia, which is transmitted to the IV catheterization. There may be a cutaneous infection and other infections. So these are the certain common sites of this hospital acquired infection. So if you see the epidemiological triad, it is mainly divided as an agent, host, as well as the environment. So mode of transmission, it is given by this agent, host, and environment, where you have an agent. The agent may be an infectious agent, and the agents may be an exogenous agent, or it may be an endogenous agent. So agents are already have given that they may be a bacteria, they may be a virus, they may be fungus, protozoa, parasite, any type of agents. Or these may be exogenous agents, or it may be endogenous agents. Exogenous agents, those who are present in the skin, mouth, nose, GI tract. And the these are the endogenous agents. Exogenous agents which comes in contact with the patient, that maybe comes from the reservoirs, that is mainly from the visitors, mainly from the equipments, mainly from the water what you drink, or maybe from the medical devices, the environment. These are all called as the exogenous. That is mainly the reservoir. Then you have a portal of exit from where this infectious things may come. It may be droplet, it may be through the secretion of the infected patient, or it may be to the excretions, or it may be the droplet infection. The mode of transmission, maybe you have a direct contact, or it may be a indirect contact. Direct contact, if you are touching a surface, if you're touching a patient who is already infectious, and without doing a proper hand hygiene or standard precaution, if you go and touch the other patient, or the healthcare provide as a healthcare providers, if you're doing a procedure on the other patient, there may be a transmission. Droplet, airborne, as well as a vector-borne transmission. The portal of entries, it may be through, as it is a airborne, it is a respiratory system, it is GI system, mucous membrane, as well as the skin. And who is a susceptible host? The patient who is there in the hospital is normally a susceptible host. So who the patient with the chronic diseases, immunocompromised diseases, very young people, the newborn, or very elderly people whose immunity has newborn and the immunity is not yet developed, or elderly people whose immunity is deteriorating. So this is a mode of infection. So the mode of transmission, where it is in the form of chain. If you are breaking the chain in any of the areas between the agent and between the host, or mode of transmission, or portal of entry or portal of exit, so you can prevent this particular healthcare associated infection. What is the impact of this healthcare associated infection? If the patient occurs the healthcare associated infection, what is the impact of this? The main impact is it increases patient suffering. Patient is already comes with some or other condition to the hospital to take care or to become a better outcome, or to come out safely without any complication. But after coming here, he may acquire some of the infection, and the suffering may increase because of it, lead to the permanent disability to the patient, or sometimes it may lead to death itself. Prolonged hospital stay. Patient might have come for 3 days, or might have come for less than 1 week, but because of the infection, because of the IV cannulation, and because of that the patient might have developed fever, and that fever is increasing and it is not coming down at all. So the prolonged, again the patient's antibody has to be changed from the first level to the second level to third level, and sometimes if it may go to 10 days or 15 days, so prolonged hospital stay, increased need of a higher level of care may require, might have come first a smaller procedure, might have develop the severe pneumonia for the patient has to be has to intubate and has to put under the ventilator, increase the cost of patients as well as the hospitals. So this is some of the impact of the healthcare associated infection. So what are the major types of healthcare associated infection, or what we call it as a common type of healthcare associated infection, which is normally given by the CDC? That is central line associated infection, catheter associated infection, ventilator associated infection, or surgical site infection are the commonest healthcare associated infection, which is given under CDC, as well as the WHO also gives this common type of healthcare associated infection. And the CDC works to monitor and prevent these infections because they are the most important threat to the patient safety, because patient has got the central line and within 1 week patient has developed a high grade of fever. Patient has got catheter, patient has developed urinary tract infection. Patient has got invasive ventilator and patient has developed pneumonia. Patient has come for the surgical surgery and patient has developed the surgical site infection. So this is main what to tell thing to worry, because this may cause a threat to the patient's life and it may cause the threat to the patient's safety too. What are the main goals for this infection control and hospital epidemiology? The main goals for this hospital infection is, first, the main goal is to protect the patient. Second one is to protect the healthcare workers, the visitors, and the other healthcare environment, and accomplish the previous two goals in a cost-effective and cost-efficient manner whenever possible. So, if we are accomplishing the first two goals, it is the automatically the third goal can be accomplished. So if you see what are the 5 pillars of the infection control, I know it is not visible, but I'll just read for you. These are the 5 pillars of the infection control, and based on these pillars, and there is something called as a strategies where you have to prevent the healthcare associated infection. First one is the isolation of the patient and the barrier precaution. Second one is the decontamination of the items as well as the supplies. Third one is that is a prudent use of antibiotics, hand washing, as well as decontamination of the environment. So whatever I've spoken, all those things, that is, any patient is there, isolation and barrier. The item and the equipment what we are using has to be they may be contaminated, visible. It is, I'm not telling it is visible, non-visibility contamination with the microorganisms. So decontamination of this. The use of antibodies. Then hand washing, which is primarily very important. The WHO and CDC says almost 30 to 50% of the cases, the all healthcare associated infection can be reduced and prevented if the healthcare workers as well as the visitors does the proper hand washing. Next one is the environmental cleanliness. So what is isolation? So first, the barrier method of the isolation, what we call it as assess the need for isolation. So I've already told you, you are at risk of getting healthcare associated infection. So these people has to be isolated. Again, the immunosuppressant people, you cannot keep them along with the other people. The people, those who are already on anti-cancerous therapy or chemotherapy, so these people has to be isolated. The people, those who are having MDR tuberculosis, open COX, these people has to be isolated. So first, As a healthcare worker, we supposed to know what is the need for the isolation. Burns patient has to be isolated from the other patient because they are more prone to get the infection. Screen all the ICU patients for the any immunological diseases, whether they are having any diarrheal diseases, skin rashes or any allergies, communicable diseases, or whether they are carriers of an epidemic strain of any bacteria. So isolate them. As we know, in the COVID pandemic, when it's initially started, the government of India has barred, or they have done a screening of the people, those who are coming from abroad, so that the infection rate won't be increasing in the country. So isolation. Next one is use of PPE, that is personal protective measures. After the COVID pandemic, I think so we are expert now. Anybody knows what is the meaning of PPE and what is the use of PPE? That is personal protective equipments. These personal protective equipments may be the gown, or along with the gown, you have also have some hospitals and all, they provide the plastic aprons, then the mask or a respirator, the glove, or you may get also the eye shield as well as the gloves. So each PP equipment has got its own action or its own use. When you touch the gloves, when you touch the body as well as the blood, any secretion, any excretion or any contamination items, you supposed to, or when you are touching any open surfaces, you supposed to wear the glove. Gown during the procedure or the care of the patient, if you are, when they contact the clothing as well as exposed skin with the blood or a body fluid or a secretion, you're supposed to wear the apron. And the mask as well as the gloves, if there is any splashes or sprays of the blood as well as the body fluid or the secretion excretion, during this time you're supposed to wear the mask as well as the gloves. So each PP has got its own uses individually. In some procedure we may not use the gown, we may use only the gloves as well as the mask. Some procedure will use the gloves, gown, mask. So each the PPE product will give you the support to minimize the risk factor for healthcare associated infection. Next one is like patient care equipments. So the handling the soiled patient care equipments. So all the patient care equipments which we are handling must be considered as contaminated, and it has to be cleaned even though it is not visibly soiled. So here, if you tell, there is something called as a cleaning and disinfection of the equipments. Cleaning, as everybody knows, cleaning means we're just cleaning the soiled things which is visibly, which is present with the it may be with the plain water or it may be the soap water, just we are cleaning it. But the disinfecting it means we are doing a disinfection with the disinfectant solutions which is available in your particular hospital, may varies, or disinfectant of the floor by what we'll call it as a hypochlorite solution. These all things will do where you disinfect in the equipment. So the when you are doing a cleanliness, the equipment may be visibly soiled or it may not be visibly soiled, but you have to do a cleaning and disinfection of the equipments. Used patient care equipments with blood, they may be soaked with or soiled with blood, body fluid, secretion and excretion should be handled carefully to prevent the skin and mucous membrane exposure. Then contamination of the clothing and the transfer of microorganism to the healthcare workers, other patients or the environment. So it has to be done very carefully. That's why we have the frequent cleanliness of your floors every day, the changing of the bed sheets. The bed sheets are soiled, then we have something called as a spill management. So if it is a blood and body fluid, if there's a secretions are there, how we have to clean it before it's sent to the laundry has to be taught to the healthcare workers as well as to the housekeeping staffs. Ensure the reusable equipments is not used for the care of the another patient until it has been cleaned and sterilized properly. It has to be done. In many of the hospital, many of the equipments and many of the probes or many of the tubings may be reusable. It is maybe based on the hospital policy, or maybe a charitable hospitals where patient may not be affordable to take the every time the new one. So there may be reusable equipments, but it has to be cleaned and then it has to be sterilized properly. Ensure the single use of items and sharps are discarded properly, because you have a sharp that is a sharp discarding container or the puncture-proof container in each hospital, in each ward you have. So properly discarding the sharp items in the particular container which is provided by the biomedical waste management. So third one is a hand hygiene. So we have seen now what is the isolation or a barrier method. We have seen the equipment cleanliness. Third one is a hand hygiene. I'm not going to speak regarding the use of antibody use. I'm going for the fourth step, that is the hand hygiene. Hand hygiene, which is known as it may be a hand washing, or it may be antiseptic hand washing, or it may be an alcohol-based hand rub, or it may be surgical hand washing. So any type of hand washing may involves in the hand hygiene. And hand hygiene, I've already told, it's very, very important for a healthcare personnel to get rid of any visibly as well as invisibly soiled things. That is hand washing, washing the hands with the plain and soap water. Antiseptic hand washing is washing with the soap as other detergents containing the antiseptic agents. And alcohol rub is rubbing the hands with the alcohol containing preparation as well as the surgical hand washing. So the 5 stages of hand transmission, how the transmission takes place, the hand transmission, or how the organisms, germs transmit in the 5 steps. That is mainly the germ present on the patient's skin and immediate patient environment. So that is the first step. That is, all of us, we should know that the organisms are present in all the environment. Second step, the germ transfer onto the healthcare worker's hand. You will go and touch the patient's surfaces, the organism will come to you. The third transmission is germs survive on your hand for several minutes. Many of the time as a healthcare professionals, we tend to forget doing hand washing, or as nurses will check the vitals, will go and give the medications, or will do the do the dressing of the patients, or change the IV or in put the that is a ringus lactis or normal saline to the patient, but we forget to do the hand washing, or we are so busy, there is no other staffs, again understaff, we tend to forget, and we, as a human tendency, normally we tend to forget and we tend to ignore to do the hand washing. But this microorganism stands, or it may survive in a hand for several minutes. Fourth one is a suboptimal or omitted hand cleaning results in the remaining this contaminated or the microorganism in a hand, and this contaminated hand transmit the germ via direct contact with the patient's or patient's immediate environment. So as a healthcare provider, we ourselves are become responsible for transmitting with our hands, transmitting the organisms from one patient to the another patient of this 5 stages. First one is from the patient who has the infection. Second one is to your hand. Third one is it without hand washing. Third and fourth one, it will remain in your hands. And the last one is contaminated hands transmit it is to the next patient. So what are the 5 moments of the hand hygiene that we supposed to know? When all we have to do the hand hygiene, as everybody knows, and like in NABH hospitals and all, it is like everywhere it is written when you supposed to do the hand washing. First, before touching the patient, before going and touching the patient for any procedure or anything to do, we supposed to do a hand washing. So that I told you, you might have touched somewhere, you might have touched the patient, another patient. So you might have, your hands might have carried certain microorganisms. So now you have to touch, you are transferring that to the next patient. So it is better before touching the patient, do the hand washing. Second one, before cleaning as well as doing any aseptic procedures, before wearing a sterile glove, going to do a dressing, going to do a catheterization, going to do a nasogastric tubing, that is application of the nasogastric tube, anything, any procedure, invasive procedure, if you're going to do, it is better you do a clean as well as aseptic procedure. You do a thorough hand washing. Third one is after body fluid exposure risk. So you might have drawn the blood, you might have did the cannulation, you might have did the catheterization, you might have cleaned the patient, you might have cleaned the vomitus of a patient. So after body fluid exposure risk, you have to, as a healthcare provider, we have to do the hand washing. Fourth one, after touching the patient, before touching, after touching a patient, and after touching the patient surrounding too, the locker, the bedside locker, the bed, anything after touching the patient, the surrounding too, we have to do the hand washing or a hand hygiene. This is everybody knows. I'm not going to tell in detail or I'm going to explain regarding the hand washing, because after the COVID pandemic, all of us are very thorough how to do our hand washing, that is with the use of a soap and water. Next one is, what are the strategies the WHO has given? Based on the evidence and the recommendation from the WHO guidelines in the year 2009, he has given the 5 core components of to improve the hand hygiene in the healthcare settings. So first one is the change the system, or there's supposed to be a system change. The alcohol-based hand rubs at point of care and assess of safe continuous water supply, soap and towels. So system change has to be there. And there may be either the hand wash or the hand cleansing in the soap and with the soap and water and water, or with the hand rub. So it has to be there at every point of care. The second the core component is training and education. The providing regular training to all the healthcare workers. It is regular, and I can tell you it is a periodic training. Every now and then reminder. Everybody knows hand washing, but giving a reminder to do the hand washing, doing an audit every now and then, so that we can see what is the compliance, whether they are complying or there is any lacunae are there. What is the cause for the lacunae? So training and education to the healthcare workers. 3, evaluation and feedback. So here we are doing the auditing, monitoring the hand hygiene practices. After monitoring, you find out for the infrastructure where each ward has got, whether it is a hand washing facilities available, whether proper water supply is there, the perception and the knowledge of the healthcare workers, while providing the results of the feedback of and taking the feedback from the healthcare workers. That is the evaluation and feedback. Fourth one, reminders in the workplace, promoting and reminding the healthcare workers every now and then for using all this preventive measures. It may be the hand hygiene, it may be the using the PPE, or it may be using the precautions, universal precaution, all those. This is a reminder in the workplace. And fifth one is the institutional safety climate. The individual active participation. It is like, it is not a what to tell individual's responsibility. It is a participatory responsibility. It is a support from the management as well as the healthcare provider. So it is an institutional safety climate. So these are the WHO guidelines or the core components to improve the hand hygiene in the healthcare settings. So most frequent infection, the risk factors because of the lack of hand hygiene. Because of the lack of hand hygiene, the most commonly you can see the urinary tract infection, because when you're doing a procedure, you may not have done properly with the precautions. So about 34% of the cases, because of the lack of the hand hygiene, the patient may get UTI. The second one is the surgical site infection, inadequate antibiotic policy or inadequate surgical preparation or wound care. There may be a chance, and as well as because of the lack of the hand hygiene. Then lower respiratory tract infection, about 13% of the cases, and blood infection, about 14% of the cases. So this is a study which is done in Maharashtra itself. It is done by N. Patwardhan as well as Satish Patwardhan. So it is Neeta and Satish Patwardhan. It is done in Aurangabad in one of the hospital. I have not given the name of that particular hospital. So they have seen the hand hygiene compliance among the healthcare workers in the super specialty hospital. And they found out this particular study among 594 health workers were represented each categories with doctors, RMOs, nurses, technicians, healthcare workers, as well as the attendants. And this is a result where they have told that the compliance is typically it is in the good compliance they have got. And the category wise, if you see, like nurses, consultants, technicians are doing the hand washing, where the RMOs as well as the attendants, there is the compliance to hand washing is little less. So they have done a comparative study between the healthcare workers. Next one is the environmental hygiene. So we have spoken regarding the hand hygiene. The fifth one is environmental hygiene. The environmental hygiene is a fundamental principle of infection prevention of the healthcare setting. That is the environment, the hygiene of the environment. So the environment be contaminated maybe from the Clostridium difficile bacteria, or it may be MRSI, or therefore appropriate hygiene of the surfaces also are very much in requirement. So these are the areas where normally we have to have a precautionary measures, or we have to have a proper hygiene of the environment. That is, once the patient is discharged, you have to do the proper cleaning as well as proper disinfection of the equipments as well as the surrounding areas. There are some strategies which is helpful in the prevention of the healthcare associated infection. I've already spoke some of the things, that is hand hygiene is already spoken, environmental hygiene, screening I've already told. There is something called as a surveillance and antibiotic stewardship and following guidelines and safety culture. So screening, I'm not going to tell, it is already told, the screening of the patient or isolation of the patient. Next one is the surveillance, a key to ongoing monitoring of the surveillance of the healthcare associated infection. So the surveillance, it is called as a continuous observation. So anything is there, you're observing continuously. For the various techniques for the surveillance have been prescribed, and it is given by the house of surveillance as well as the targeted surveillance. So continuous observation of these particular infections is done under the surveillance. The main objective of this surveillance is identifying the risk factors. I've already spoken regarding the risk factors. So identifying this risk factor, reducing the infection rate of this risk factors, establishing the baseline rates, identifying the outbreaks. So when the COVID pandemic started, everybody we knew they have studied, they have done very thorough study regarding the occurrence of this COVID, how it comes. That's why they have told maybe a airborne disease, so you have to wear a mask, then hand washing. So identifying the outbreak and do the proper precaution, then evaluate the control measures, document whatever the infection is there, please document it and compare the hospital's infection, healthcare associated infection. So this is given the surveillance loop. So it gives you regarding the mainly regarding the main aspects of this healthcare system. In the healthcare system, any event takes place, any event mean any infection, what I mean to say. So it has to be reported. The data has to go to the surveillance center, which is there. It may be your hospital, may be a surveillance, or it may be in the district, it may be in this state, it has to go to the particular center, and they will do the analysis and interpretation of that, the information and the feedback, and what has to be done. The recommendation is given back to the healthcare system for the action. So this is a loop which going to happen, and it is a cyclic measure where we can, majority of the time, we can prevent this particular healthcare associated infections. So under the CDC, it is given the prevention of the healthcare associated infection. That is, they have given various tools are developed in order to assess the infection rate and prevent the practices and guide quality improvement activities. So the very infection control assessment tools are developed by the CDCs, and these tools may also be used by the healthcare facilities, and each hospitals also have their own tools in order to assess this particular infections. The targeted assessment for the prevention strategies and the prevention toolkits. If SSI, if the surgical site infection occur, how to prevent it? There is a toolkit. If there is a CLUPSI occurs, what is the toolkit? Basic infection control as well as a prevention plan has to be there as a policy or a guideline in any healthcare association. So prevent the central line, that is a bloodstream infection, that is a CLUPSI. And briefly, I will tell you because this itself is a big topic. So how to prevent this? It is better to remove the unnecessary central lines. If it is not required, it is better to remove that. Follow the, it is not given by us, it is given by the CDCs, that is the Center of Disease Control Center. Follow the proper insertion practices, that is sterile practice. Facilitate proper insertion practices and comply with the hand hygiene as recommended by the CDCs. Use adequate skin antisepsis, choose proper central line insertion site, and perform adequate hub or the access point disinfection, and provide education on central line maintenance as well as the insertion to the healthcare providers. And there's supposed to be a guideline for an insertion checklist for the insertion as well as for removing, and how to give a care. So in ICUs and all these guidelines, if they are available, it will help you to reduce the infection which is caused by the central line association. Next one is that is a catheter associated urinary tract infections. So here also insert the catheters only if it is required. Leave the catheters in place only as long as needed. Don't keep the catheters for longer duration of time. If it is there, then in 14 days, it is better you change the catheter. Ensure that only properly trained personnel only insert this particular catheters. Insert the catheters using aseptic techniques as well as sterile techniques. Follow the aseptic insertion as well as maintain always the closed drainage system. Don't keep the hub open. Maintain the unobstructed urine flow and always follow the hand hygiene. If it is a surgical site infection, I'm not going to speak in detail of this because already Dr. Savia has explained to you before surgery, during the surgery, as well as the after the surgery. So before the surgery, administering the antimicrobial prophylaxis at least 1 hour before the surgery. If any infection is there, first tackle with the infection. No removing the hair or shaving the hair. Instead of that, it is the clipping which is done, and skin preparation with the antiseptic agents. During the surgery, the operation room theater has to be, door has to be closed, and except it is needed for the passage for the equipment as well as the personnel as well as the patient. And after the surgery also, the patient has to be protected at least for 20, the surgery site has to be protected at least for 24 to 48 hours. And discontinuation of the antibiotics within 24 hours after the surgery time is over. And prevention of the Clostridium domicili infection, which is this particular infection is it's inflammation of the colon, which is caused by this particular bacteria. So we have to take precautions. If the patient comes with a diarrhea, we have to find out what is the cause. Hand hygiene has to be followed according to as compliance with CDC and WHO. Cleaning and disinfection of the equipment as well as the environment. Laboratory based alert system for immediate notification has to be given if the result is positive, and this notification has to be sent for the surveillance department or the department for the infection notification center, or educate the housekeeping, healthcare workers, administration department, patients, as well as the family members. And prevention of MRSA infection, proper hand hygiene, implement the contact precaution, recognize previously colonized patient. You recognize patient and isolate the patient, report the lab report of MRSA positive, and provide MRSA education to the healthcare provider, and periodically doing the MRSA for the patient. And for other surgical patient, it is better to do whenever the patient is posted for the surgery. And in the infection control, in the prevention of the health related infection control, the infection control committee has got very important role in the prevention of the healthcare associated infection. Every hospital must have a well organized and well equipped health acquired infection control committee, and responsible for the control of the HAIs. The role of the infection control committee is mainly responsibility is for planning, evaluation of the evidence-based practices and the implementation, prioritization of the resource allocation, and all the matters related to the infection control. Anything matters related to the policy, planning, giving a education, giving training to the healthcare providers, housekeeping workers, as well as to the patients and their attenders, developing and disseminating infection control policies, various policies for the various procedures, monitoring and periodic auditing the hygiene. It may be a hand hygiene, it may be a biomedical waste management handling, and the clinical audit for the various procedure by using like catheter. There may be a various bundles are there in order to do the in order to monitor the various infections of it may be a VAP, it may be a CLEPSI, it may be COTI, there may be surgical site infection monitoring checklist is there. So periodic clinical auditing, this is a responsibility of the infection control committee. So these are some of the tools which is provided by the various organization. And if you see, there is CDC also is given various tools, and these are the care bundles, like you have urinary catheter care bundle, like that you have other care bundles also. What are the challenges of the healthcare associated infection control? Increasing the main challenges are there is increasing emerging infections. Many infections are coming, and the resistance of the organisms are increased for the first line drugs, the second line drugs, as well as the third line drugs. Increasing drug cost, as well as institution medicine report, healthcare associated infection. The nursing shortage is another challenge. Because of that, the many of the procedures we are not doing as per the procedure we're supposed to do. And there may be a multiple benchmark system, and main legislations are given for the reuse of the single-use devices. That's what I told, the tubes what we are using, or the equipments what we are using, there may be a reuse legislations are given. So these are all challenges we may tend to come on our way while doing the health associated infection. So preventing all this infection requires, first one is a knowledge. As a healthcare provider, we're supposed to have a knowledge, thorough knowledge regarding the type of diseases, the transmission mode or a mode of transmission, who are the agent, who are the host, what is the reservoir, what is the mode of transmission, exit, entry, which are the organisms, all those things. As a healthcare providers, we supposed to have a knowledge. We require a proper attitude towards attitude that is committed ourselves to preventing the healthcare associated infection, as well as being effective team members in the healthcare team, where you will help the infection control team also to find the infection, to do the audit, or to prevent the infection, and requires skills. So healthcare is everybody's responsibility. It is not only responsibility of healthcare providers. It is everybody's responsibility, and we get involved and together in the healthcare system, and we can stop the hospital acquired or a healthcare associated infections. So together we can fight against the infection. Thank you.
Hello. Thank you so much, madam, for sharing insight into hospital-acquired infection. I'm sure that everyone will now have empathetically work towards patient care and prevent all the cross infections. Thank you, Preeti ma'am. Moving further, I request Mrs. Pratnya Saman ma'am, Pratnya Kadam ma'am, if ma'am wants to share few thoughts on this webinar.
Thank you, Priyanka madam. Good afternoon, everyone. Respected online presentation for the webinar. Myself, Mrs.
Your
Pratnya
voice
Kadam,
is,
MSc.
yeah, ma'am, your voice is not audible.
Hello.
Yes, ma'am, it's audible now.
Okay, good afternoon, everyone. Respected online presentation for the webinar. Myself, Mrs. Pratnya Kadam, MNC Observer. Maharashtra Nursing Council is proud of its registered nurses and congratulate every single one for their incredible services to the mankind during this dreadful COVID-19 pandemic. Myself, the spirit of service belong live among each of our nurses. So regarding webinars, start from the organization, and they are hello. Regarding webinars, start from the organization till it is a quick response. They are very communicative. Start from on time, easy enrollment, quick response, started in time, finish in time, started with pre-test. Speaker was excellent. That is respective madam, Dr. Philomena madam, Padmaja madam, then Dr. Sylvia Fernandez madam, Dr. Meera Athrekar madam, Dr. Maria Matthew madam. They are excellent academicians, delivered the excellent, informative and knowledgeable session in easy language, cover all points. Session ended with the feedback. On behalf of the MNC, I am appreciating the management and MGM New Bombay College of Nursing team for organizing this fruitful webinar. For our nurses to update their knowledge regarding patient safety and an overview. Thank you, everyone. Thank you, Priyanka.
Thank you so much, ma'am, for such wonderful words. I, Ms. Priyanka Khedekar, on behalf of MGM New Bombay College of Nursing, Kamote, thank all participants for their patient listening and cooperating with us. I hope this webinar was helpful for them in their daily routine as a nursing profession. Our eminent speakers for taking out time from their busy schedules and sharing their thoughts on this patient safety. And special thanks to you, ma'am, as an MNC observer, taking out time and sharing your thoughts on the same. I now declare that all the participants have given their posters, submitted the feedback form, and we are towards the conclusion of this session. I just, as a conclusion, as a concluding thoughts, I would like to share the very first requirement in hospital is that, as Meera ma'am said, it should do the sick no harm. I hope all participants have filled up their posters and feedback form. Thank you so much. Thank you, ma'am. Thank you so much, all the participants.